السلام عليكم، مساء الخير جميعا. يعطيكم العافية. Welcome everyone. أعتقد أنتظر أفضل 10 دقائق بس لين يجتمع عدد أكبر، ويمكن نعطي فرصة للي يبغى يصلي العصر بما أنه أذن الآن، ونرجع بإذن الله after 10 minutes مباشرة بإذن الله. Thank you. طيب بسم الله الرحمن الرحيم. السلام عليكم جميعا، يعطيكم العافية. أهلا وسهلا. Welcome to our session today. Yesterday I received a comment from program coordinators. They told me that I should speak frequently Arabic في الليكتشر علشان الناس يمكن يكون أسهل عليها. I believed in there might be some foreign people, not Arab, with us, and maybe I considered that all of us are healthcare workers, so it's better to communicate in English, especially in education level. However, I'll try to explain and translate the slides whenever I go through. And if it is really complicated or difficult for you guys, you can ask me later. Keep your questions at the end of each session, please. And I will be happy to answer all of you guys. So today we will have, inshallah, with me 3 lectures. First, we will start with the most interesting topic to me, actually, multi-drug resistant organisms. This topic is really a huge chapter in infection prevention world. And I can't tell you guys how important it is and how it's being centralized of most of researches recently, and most of medical research are focusing on the threatening phase of multi-drug resistance in the whole world now. So this topic is really crucial, important, and I believe as long as you are listening to me from infection control team or quality team, please try to advise your team, try to advise your facility member that this is really threatening. And according to the latest study, by 2050, MDROs will be #1 life-threatening cause of death. So from there, I can say this is crucial. And let us as infection preventionists and healthcare providers focus, please, on our roles and how can we help to reduce the rate of MDRO in healthcare facilities by promoting the standards, infection control standards, by being a role model, a very good role model, and emphasizing knowledge through the staff, patients, visitors, families, etc., and the community as well. So the outline for today will be a short abstract, hopefully short, some definitions, and the clinical presentation of MDRO patients by their symptoms, and multi-drug resistant organism management as in term of case. If you have a case in your hospital, how you manage that case, MDRO patient care bundle data, and epidemiology and prevention of MDRO outbreak whenever indicated or happened. MDRO's prevention strategies, some of them that which I want to close up the lecture with, and finally cleaning procedure for transmission-based precaution and isolation wards. As an abstract, we know that although infection prevention traditionally has approached to the problem of resistance primarily from the aspect of preventing transmission, and mainly احنا نحاول mainly to prevent transmission of the infection itself. However, what we need to know more, what we need to emphasize more, what we need to invest our knowledge in more is to control how antimicrobial are commonly used. Why? Because antimicrobial use is the main selective pressure responsible for the increase of multi-drug resistance seen in hospitals. So although we are always trying to prevent the transmission of infection, however, we should try to know what caused this infection, what can make the pathogens be multi-drug resistance. Then, because on that level, we cannot fight something very strong. Do you understand what I mean? So next, patient come to a resistant level of resistant pathogen, either with 2 ways. Either he is having the bacteria acquired the gene that code for resistance. The bacteria itself has the code of resistance by time, by long-term treatment, by long-term hospitalization of that patient. And the bacteria, it takes the bacteria like days or weeks to develop that gene within the bacteria itself, okay? Or the resistance could be happened by transmitting resistance bacteria already from one person to the patient, which requires only a handshake, which requires only a contaminated hand, which requires only poor hand hygiene, for example, okay? To have an impact on antimicrobial use and to reduce the resistance of any bacteria, infection preventionists need to work and increase their knowledge of available antimicrobials already. The antimicrobials that we have, we need to increase our knowledge about them and how we utilize them, how we use them effectively to avoid getting bacteria resistance to all our antibiotics that we have got now. So appropriate use of the antibiotics, and we should know also the mechanism, how the antibiotic could inhibit microbial growth, and also the mechanisms that develop the resistance in the bacteria itself. This extensive knowledge could lead us to reduce MDRO rates, if you agree with me. In addition, infection preventionists need to understand promising new strategies, promising new researches that can improve antimicrobial use. Also, we can use community awareness, can become more involvement to help us to reduce MDRO's rates. For example, in case of viral infection, never taken bacterial antibiotic, never, because this is a contraindication with the other one. Bacterial antibiotic cannot treat viral infection. Yeah. So in this case, if we increase the community awareness about antimicrobial use and how they should stick to the prescription and duration and the dose and all these kind of things, this could help to reduce MDRO's rate in our community too. Also, two aspects can help to decrease the antimicrobial resistance in healthcare settings, which is antimicrobial stewardship and the antibiogram. Antimicrobial stewardship is the best investment for preventing the multi-drug resistant pathogens and the adverse events associated with these drugs have been used. Okay, this is the responsibility of antimicrobial stewardship program, which consists of clinical pharmacist, microbiologist, infection preventionist, medical director, physician. I believe those are the core components who should attend the stewardship program. Also, an antibiogram is a useful tool for infection preventionists to determine the status of strategies in place to reduce MDRO pathogens. Antibiogram is mainly a work that is between pharmacy and microbiology in lab, and mainly it's focused on antimicrobial use and the resistance pathogens trends in the community. So this what can antimicrobial be used and report this kind of information. Moreover, surveillance, MDRO surveillance is a quite essential first step in identifying priority areas for managing antimicrobial use for an infection prevention perspective, from an infection prevention perspective versus a pharmacy or cost-safe perspective. So surveillance data is important. It can show us where are the weakness points in the facility, what are the sources, the common sources of multi-drug resistant pathogens in the hospital, and also it can give us where we are. Are we in threatening level? Are we in outbreak level? Are we in endemic level? Are we in where we are? So surveillance could guide us and give us a screenshot about the whole situation in the hospital with MDROs. In addition, infection preventionists should consider tracking the number of patients whom are found or routinely cultured to be newly colonized either or infected with resistance pathogens such as MRSA, VRE, C. difficile. So whenever we are concerning about a patient with MRSA, VRE, this patient could be a risk factor of MRSA, VRE, C. difficile. We should screen those patients routinely, especially if they are admitted to a high-risk critical areas such as ICUs, NICU, PICUs, OR, for example, need to be screened actually to eliminate and isolate these patients and treat them in contact precaution pathway. The spread of these forms of resistance may be expressed as an episodes, individual cases of newly detected colonizations or infections per 100 admission or 1,000 patient days. So this is how the surveillance data will be describing. This information is crucial for infection prevention efforts aimed at controlling resistant and antimicrobial use quality improvement tool. So surveillance can help infection preventionists to develop and use quality improvement tools, KPIs, or any quality tools to improve to do the reduction of MDRO rate in the hospital. Laboratory and infection prevention personnel should have an effective communication with regards to the possible emergence of sentinel resistance patterns, such as vancomycin resistance in Staph aureus. So any trending, any abnormal pathogen, any unusual pathogens should be reported from laboratory team to infection control team immediately so they can control the case and investigate for the causes and the roots and the reasons. MDRO definition, they are defined as microorganisms, mainly bacteria, which are resistant to one or more classes of antimicrobial agents. Although the names of certain MDROs, such as methicillin-resistant Staph aureus or vancomycin-resistant Enterobacteriaceae, those pathogens are not resistant to only that class. However, they frequently resistant to most available antimicrobial agents too. Examples of MDROs as a gram-positive MDRO, we have MRSA, the classic one, and VRE, of course. From gram-negative side, MDRO, we have Klebsiella carbapenem resistance Enterobacteriaceae. We call it CRE, MDR Acinetobacter, MDR Klebsiella, or Pseudomonas, or ESBLs species. What are ESBLs? They are bacteria, gram-negative bacteria, which are resistant to extend-spectrum beta-lactamase antibiotics. They usually developed an enzyme that inactivate penicillin and cephalosporin drugs. Moving from the introduction to the and definition to the clinical presentation of MDRO by symptoms. How can we classify the patient by symptoms with MDRO infection? So MDRO infection could be colonization or active infection. When we talk about colonization, here I should mention that it is the multiplication of the microorganism at the body site without any clinical sign and symptoms. ما في أي إشارات ولا علامات إنه هنا في infection في المريض, and this is how it is dangerous from my point of view. That's why we always say implement standard precaution with everyone, because you never know. This patient might be colonized, might have a very resistant bacteria. However, there is no sign and symptoms. It's silent infection, I call it. Therefore, there is no clinical signs and symptoms. Also, no detected any immune reaction. ما في أي ردة فعل مناعية from the host At the time we collect the sample and microorganism is isolated from the patient. This is really risky. It may or may not cause an infection to others, but it may be form as a potential source of transmission, and it doesn't need any treatment. It doesn't need any antibiotic. It doesn't need any treatment. The colonization, okay? It's silent infection. Whereas active infection, it is a successful transmission of microorganism to the host. The microorganism could multiply, colonize, invade, cause harm with signs and symptoms. Okay? This infection may be clinical or subclinical and may not produce identifiable disease. It cause harm, however, ما لها علاقة تكون مرض لكن حتكون عدوى. Okay? However, it is usually measured by host immune response. إيش الhost immune response? We have two types: specific antibody reaction ولا cell-mediated reactions. Active infection required treatment. Required antibiotic as needed, of course. Right. Now, if we have MDRO case in our facility and we need policy procedure to manage this case, to, facilitate this case properly, we should go through many aspects, from admin aspect to medical aspect, nursing aspect, infection control follow-up, and all kind of this stuff. So going through from the first thing, microbiology lab will notify the infection control team through their report, through communication, what they agreed on, telephone, email, whatever, paperwork, whatever. So a microbiology lab will notify the infection control team. If the patient will have previously history discharged with MDRO positive, he should be flagged in the system or in the documentation that he has previously had MDRO, and infection control staff should know this information. After that, management of MDRO positive patient. Now we have positive patients in the facility. We need to manage this case. What we should do? First, initiate contact precaution. In addition to standard precaution, initiate immediately with the patient file documentation. Infection control team should inform the nursing team, coordinate with the facility or the ward the patient is in, this kind of thing. Patient must be in a single room, or not must be, possibly or preferably, or it can be cohort with another patient with the same organism, okay? MDRO positive patients who are in multi-bedroom can be managed temporarily in a smart way, like keeping the patient in the corner, keep the curtains closed until you facilitate a suitable place to place this patient in. Next, place a sign on the cubicle or the curtain of the patient bed. Ensure easy access to the PPEs, personal protective equipment, and alcohol-based hand rub. Of course, practice a strict standard precaution between interactions with patients in the same room. Transfer to the single room, if possible, or cohort with the same organism patient. Place a contact isolation sign on the outside of the isolation room door. Practice a strict hand hygiene whenever indicated, following your 5 moments of hand hygiene. Remind your team usually with the 5 moments. Remind them with the 5 moments, not only just tell them practice hand hygiene. No, remind them with the 5 moments, because sometimes they have a break inside the 5 moments. They missed some of these moments, which can lead to serious infections actually. Next, cohort non-critical items such as a stethoscope, pressure cuffs with the patient. Keep it with the patient room, dedicated for one patient, or you can share it, but maintain clean disinfect between patients, okay? Store the minimum amount of supplies in the patient room. Don't exceed the level of supplies inside there, because after patient discharge, you will throw those resources all away, okay? Use an isolation card for extra supplies. Keep it outside the room. Ensure that all staff understand and comply. How? By education. How? By monitoring. How? By ward visiting, by doing your rounds, okay, daily basis, especially focus on these isolated patients because they are the main source of infections. Ensure that all staff understand, comply with the isolation precautions and hygiene protocol. Next, limit the patient activity outside the room. Let the patient go out only for treatment or tests, only for medical purposes. Notify receiving departments and wards such as radiology, endoscopy clinics, or OR that the patient is in isolation status, and use the transportation card on the patient file whenever he is moving. Next, ensure ensure terminal cleaning for the isolation room that has been done properly per housekeeping procedure. Handle and discard contaminated items as per standard precautions. Medical team, you should request an ID consultant as needed, which is better because ID consultant actually, they have a very crucial role in helping physicians and the rest of the team in antibiotic prescriptions. So the better you involve, when the ID consultant is involving, the better outcome it is. Discharge the patient when clinically condition is allowed. Regarding the clearance, discontinue of isolation, this should be done after the consultation with the infection control team. They should follow certain standards, protocols, policies that they have usually. Screening of healthcare workers and environment is not recommended. However, it should be initiated when indicated by infection control department team. Outbreak management. Management of an outbreak will be coordinated and initiated actually by infection control team, and it requires a cooperation with medical, nursing, laboratory, and other departments. Cleaning of the patient room should be performed regularly and terminally, daily basis, terminally after patient is discharged, okay, following a housekeeping protocol. Linen, keep the linen humber in isolation area. Separate infectious linen from non-infectious linen. Now we are going to talk about MDRO prevention strategies, and one of these strategies emphasized by MOH recently is very nice standards and chapters. They share it with us. It is mainly focused on the components of MDRO bundle. So we are going to talk what is MDRO bundle, what is the how we can use the bundle effectively, and what is the concept of the bundle itself. I'm going to go through these 5 items intensively. Mainly they will focus on administrative measures, structure and system administrative support is very important in order to reduce MDRO rate in any facility. Number 2, prevention MDRO transmission by emphasizing infection control measures, of course. Number 3, wise use of antimicrobial by activation of antimicrobial stewardship program in the hospital, support from the administration level in all aspects, financially, human resource, researches, supplies, all these kind of stuff will help. Number 4, MDRO surveillance, as I said, will give us a screenshot of our situation, where we are and where we want to go. Okay. Number 5, education and training of healthcare personnel is quite important. Also, education for patients and visitors and their families and watchers whenever possible. First, administration measures. Human resources, as I said, train infection control practitioner and adequate staff level. Staff ratio number is very important. You cannot ask nurses to do all the 5 moments of hand hygiene, perform excellent PPE donning and doffing with a very minimum amount of nurses in front of a very huge number of patients, of course. So human resources here is quite important. implement system changes to ensure, promote, and effective communication, such as computer alerts. I found computer alerts for MDROs, flagging MDRO in the system, give them a red flag beside their medical record number is quite important. It helps the first liner people to understand that this patient is under isolation and this patient is a high risk. So they do the first initial step by isolate the patient immediately, initiate precautions as from the beginning. This all is really very good factors and helping actions, actually. Providing hand hygiene facilities, adequate hand hygiene facilities, and environmental cleaning. Maintain the environment clean and disinfect. Enforce adherence to recommended infection control practices and compliance monitoring, of course, for the staff. Follow up, like who try to follow up every day your healthcare workers, how they implement infection control practices inside the facility. Feedback to the healthcare workers, share with them the KPIs, share with them the rates, share with them all the data. After counseling with your boss, after counseling with the administration level, share the data with the team. Let them know that there is a risk of infection. Let them know there is a break in infection prevention measures. Let them know that they can help to change these percentages by time. So sharing and feedback is increasing of a good communication between teams, between nursing, physician, infection control team, pharmacy team, laboratory team, etc. Written plan for implementation. Whenever we have a problem such as MDRO increase, such as incidence reports, we need to write a plan to be implemented to give the staff a structure to work on. Okay. Sorry, the slide is not moving. Okay. Next, prevention of MDRO transmission by what? Infection control measure adherence. So improvement in hand hygiene compliance, let's say above 90%, make the rate to reach above 90%, 80%, that's cool, okay? PPE, wear gloves and gown whenever entering the patient room and removing them before exiting from the patient area. Active surveillance culture, such as detecting asymptomatic patients. Those are the hidden threat, actually, which patient I mean with the silent infections, the asymptomatic, the colonized patients. Those should be screened, actually, and just to know the situation of them. Use of isolation precautions, standard precaution, and contact for patient colonized and infected with MDRO, of course. Follow recommended cleaning, disinfection, and sterilization for maintaining patient care areas and equipment as clean and disinfected as possible. Disinfect reusable medical equipment between patients, of course, to avoid cross-contamination between patients. And increase cleaning and disinfection of frequently touched surfaces, of course, because they are frequently touched. Monitor, supervise, and inspect cleaning performance by housekeepers. Make sure that they follow the standard, the protocol, the policy procedures. Wise use of antimicrobials from the doctor's sides. Limit antimicrobial prescriptions. Now, انتوا عارفين أكيد إحنا قاعدين نحكي, we are talking about strategies that minimize or reduce MDRO risk. So إحنا الحين وصلنا رقم 3. One of them is limiting antimicrobial prescription. Second, use local antibiogram to effectively treat infections. لأن الantibiogram can lead us to better view what we should use, what antibiotic we should use, based on the trends that we have, the strains, microorganism strains that we have now. Okay, treat infections, not contaminations, please. Make sure that the sample is infection, not contaminated sample. Okay, make sure double check with the lab report. Treat infections, not colonizations, please, not colonizations. Stop treatment when infectious is cured or unlikely to be happened. Avoid excessive duration of treatment, and use narrow spectrum. Use narrow spectrum antibiotics instead of broad spectrums, okay? Number 4, MDRO surveillance. As we say, surveillance is a very important tool. It can give you a screenshot of the whole picture. A critical component of any MDRO control program is the surveillance, of course. It focuses on the importance patient safety component, allow detection of newly emerging resistance patterns, monitoring epidemiologic trends and incidence of MDRO over time, and it measures the effectiveness of interventions have been done in the plans. Okay, لأن إحنا من surveillance we can create our plans to إيش to structure الموضوع علشان نرتب موضوع MDRO, how to reduct the rate of MDRO. So from the surveillance we can write our plan, our interventions, our goals, where we want to go, and from there we can start. Education, facility-wide education, unit target education, informal, formal, whatever kind of education you can do, just do. In service, for example, just do. Educate your team, increase their knowledge about MDRO, how much they are really threatening, educate interventions for prevention of MDRO transmission, and provide basic education to the patient, visitor, very primary, basic infection control measures. Now I'm going to explain what is the care bundle, MDRO care bundle components. What is it? Care bundles is a series of evidence-based practices and interventions related to a device or a process of care. هذا تعريفها. Okay, that when implemented together, البundles هذه, when they implemented together, will achieve significantly better outcomes than when we implement them individually. That's why we gathered many practices in one bundle to achieve better outcome. Bundle is an implementation tool aiming to improve the care process and patient outcome. بس إيش in structured manner, يعني مدروسة ومرتبة. It has a small, straightforward set of evidence-based practices, generally من 3 إلى 5 إيش practices, proven to improve patient outcome when performed مع بعض. Okay? For example, MDRO bundle aim to prevent antimicrobial resistance in when free in patients, outpatient location, and where MDRO data are collected. هذه ميزة البندل. This care checklist هي عبارة عن checklist has many has many practices فيها. This care checklist should be used with patients who are known to have an MDRO and isolated on advisement infection control team. Each criteria on this checklist should be ticked with Y يعني yes, or placed N يعني no, or not applicable لما تكون not applicable, and تتوقع في الأخير after completion daily. MDRO patient care bundle. إيش فيها? What it consists of? Patient placement, يعني risk assessment للpatient placement. Is the patient is cohorted or in a single room? Is he required a single room أساساً? Or it's okay, he can be cohorted with other patients. So this is number 1. Number 2, standard infection control and transmission-based precautions, including hand hygiene, personal protective equipment. Is it done? Is it applicable للpatient هذا? Is it available? Is there enough supplies of hand hygiene products and PPEs? We should check and tick. Okay, check and tick. Number 3, safe management of care equipment. Decontamination of the patient equipment by healthcare worker is in place using a chlorine-based detergent with 5 minutes contact time before rinsing off and dry. So we should check and tick. during our rounds daily for the isolated patients with MDROs. Number 4, safe management of care environment. Is the environment in the patient clean? Patient toilet, patient bed, patient surrounding, patient laundry, patient linen. Is it all clean? Check and tick. Number 5, clinical healthcare waste. Does the patient have a yellow bag, waste bin in his room? Does the waste, medical waste has been discharged correctly? Check and tick. Number 6, education for patient and their family. Is it done? Has it performed and documented in patient file? Check and tick. Required PPE, of course, as you know, we have 3 types of isolation precautions. And in case of MDROs are falling under, of course, contact precaution. مو droplet ولا airborne. They fall under contact precaution. So all healthcare workers should be instructed to first practice hand hygiene before touching any supplies, then wear isolation gown and gloves before entering into the patient room. Next, before leaving the patient room, remove the gown and gloves, perform hand hygiene. Okay, this is in case of the patient is infected with MDROs. إحنا هنا. Okay. Sequence of donning and doffing للPPE is quite important. According to the CDC, we have a picture. I will show it next slide. However, donning, we have 1-time hand hygiene. Remember this for me, please. Doffing, we have 3-time hand hygiene to be performed. Okay? Please don't forget this screen. So during donning PPE, first you should do hand hygiene properly. If your hands are visibly soiled, you should do hand washing. If they are not, hand rubbing is enough with alcohol hand rub. Okay? Next, you don your gown, then your mask or respirator, then the face shield or goggles if needed, then the gloves. طبعا هذه مو للcontact precaution, هذا PPE donning and doffing in general. Okay? When doffing, remove the gloves because they are the highly contaminated parts from your PPEs. So we need to eliminate the high source of infection or contamination with you now will be the gloves. So احنا بنشيل أكثر شيء ملوث من ال PPE معانا. First thing is the gloves. So discard your gloves, do hand hygiene, remove the facial or goggles, perform hand hygiene again. ليه? Because I'm going to touch my face here. Face mask or respirator. Whenever you're going to touch your face or remove something from your face, you should perform hand hygiene. Remember this. عشان كذا هنا في hand hygiene وهنا في. Because after it, you will touch your face. You get my point? And at the end, perform hand hygiene because the mask might be contaminated. Okay? This is the posts. Of course, you know this all of you, from the CDC. Sequence of putting on and sequence of removing the personal protective equipments. Moving to epidemiology and prevention of MDRO outbreaks. MDROs can often cause an outbreaks in any healthcare facilities if they are not well monitored and staff not took them seriously, actually. And the factor contributing to MDROs outbreak in healthcare settings are these: selective pressure of extracted by exposure to antimicrobial in the community, inappropriate and uncontrolled use of antimicrobial agents in healthcare settings, inadequate adherence to infection control measures, contact with colonized or infected patients, like, for example, lack of isolation, availability of susceptible hosts. Whenever you have elderly people, whenever you have infants, whenever you have immunocompromised, whenever you have transplant patients, whenever you have oncology patients, the risk will be increased. Now, how to clean a place, a patient room who is occupied with multi-drug resistant bacteria. So here they said these areas are high-risk areas, especially for environmentally hard pathogens resistant to disinfectants. and multi-drug resistance. So cleaning procedure for transmission-based precautions, isolation wards. For example, patient who diagnosed with Clostridium difficile, he should be on contact precautions. So how frequent should the room be cleaned? Twice daily and as needed. Who will do the cleaning? Of course, the cleaning staff. Method to be used: a clean and disinfect 2 steps process required. Sporicidal, of course, in case of Clostridium difficile, because it's a bacteria that produces spores. And 2 steps process required. Not use combined detergent disinfectant. You will find these guidelines in MOH. Thank you, guys. I believe I'm done. If you have any questions, I'll check the question and answer box. Hopefully all went good. Oh my God, في أحد يقول I cannot hear anything. Okay. Oh, thanks. You're welcome, Abdul Majid. Any questions, guys? Good. So let's take 5 minutes break and come back to the next lecture. بسم الله الرحمن الرحيم. مساء الخير جميعا. Welcome again. أهلا وسهلا. Thanks for listening. And now we're going to move on to the next topic, which is the role of environmental cleaning and disinfection in patient safety. Our outline for today, short abstract, of course, healthcare environment types, basic principles about environmental services, microorganisms, VCs, environment, survival time, environmental services, cleaning agents and special circumstances, mattress and pillows management, waste management, pest control, environmental gram-negative bacilli, and hospital environment recommendations. I know it seems a lot. Bear with me. As an abstract, there is an increasing evidence that the healthcare environment is an important source of healthcare-associated infections, unfortunately. Of course, the environment is one of the sources of infections in any healthcare settings. So every facility must truly clean its environment to prevent it from developing into being a reservoir for pathogens, of course. The cleaning needs vary by facility and based on the assist by team experts. So the experts are responsible for providing the leadership by establishing effective cleaning protocol, preparing regular cleaning schedule, writing the policies and procedures for the housekeeping, selecting the appropriate cleaning agents and equipment, and hiring and training for the staff as well. Okay. So individuals responsible for selecting, purchasing, and educating others on the use of cleaning products should have the thorough understanding of the terminology and should be knowledgeable about the efficient and intent use of different chemical agents. So the terminology of, for example, the difference between disinfectant and detergents. For example, the difference between high-level disinfection, low-level disinfection, intermediate disinfection, all this kind of terminology. Those leaders, they should understand this language and educate others about it. They are also prepared to address unexpected situations such as outbreak, natural disasters, backorder on supplies, unavailability of equipment, and staff shortage. All those things, they should be monitored by those leaders. Proper education and training of environment. طيب بتقول لي الدكتورة ما تتغير. دقيقة يا جماعة. لا إله إلا الله. مرحبا، كيف الحين؟ تغيرت؟ Can anyone write to me? Yes, تغيرت؟ عبد المجيد? Okay, thank you. So those were the outline. اوكي تمام الحمد لله. معلش guys نفس مشكلة أمس. Okay. As we said, they also prepare and address all situations such as outbreak, natural disasters, back orders on supplies. مثلا, if the supplies are not equivalent, not with high quality, and unavailability of equipment and staff shortage, they should report all these kind of stuff. Proper education and training of environmental services personnel are critical component of the effectiveness of the program, of course. Staff must be educated and trained upon hiring and regular basis as well. Biohazard and non-biohazard waste must be separated. Environmental services address pest control. Programs should be developed to assess the efficiency of the environmental services activities. Even when performance improvement measures are outstanding, there is always a room of improvement, of course. So monitoring, scheduling, observations is very important to use them in improvement tools. Patient, visitors, personnel expected and deserve a clean environment. Okay, this lecture addresses the mainly focusing on hand hygiene, disinfection, bloodborne pathogen exposure, laundry of linen, waste management practices as applicable to environmental services. So this is mainly the focus of this lecture. Healthcare environment types. Actually, we have two healthcare environment types. First one with minimal hand contact, such as floors, ceilings, and other one with high frequently contact touches surfaces. High touch surfaces may be potential reservoir for microorganisms. Why? Because they are frequently touched. Okay, these surfaces need to be cleaned often, need to be cleaned more frequently, because contact with them may easily lead to cross-contamination of infection, of course. Items or services that are less frequently handled, هذا النوع الثاني من الenvironment, may not need to be cleaned frequently because they experience fewer contact and they are less likely to be a source of infection. To prevent the dust and soils, cleaning activity should be conducted with minimal disruption. Okay. Basic principles about environmental services. Accumulating a dust or soil or microbial contamination on an environment service and healthcare facility is not only not our desire, but its evidence indicate that is also play a major role spread of healthcare associated infection. It's not about the convenience in the environment, just that reason. It's about the environment will be a good reservoir of microorganism multiplication. Yeah. So contact with contaminated surfaces easily lead to cross-transmission of microorganisms between people and the environment. The hands of healthcare personnel become contaminated while providing care to a colonized or infected patient. Healthcare personnel then touch the contaminated, with their hands contaminated, any inanimate object in the environment surrounding the patient, and then the patient will spread this flora and these organisms on the surface again to let any other else to contact it again. وهكذا. So the surface is not properly clean, the cycle will be continued, of course, for a long period of time. Susceptible individuals can become colonized or infected from these environmental pathogens, of course. Microorganisms versus environmental survivals. As we know, the microorganisms can survive on the environment for a long time. But this period of time is diverse or is vary from microorganism, excuse me, to another. Studies have shown that many microorganisms survive on surfaces for a long period of time. For example, Staph aureus, including MRSA, survive more than 12 months. Enterococcus, including vancomycin resistance, lives more than 46 months, and that's a very, very long time. Clostridium difficile can live more than 5 months on the surface, and norovirus can stay there for 2 weeks. Among the hardly gram-negative bacilli, Acinetobacter and Pseudomonas aeruginosa have been isolated from the environment 11 and 16 months later. Klebsiella has listed more than 30 months. So مين أعلى أحد هنا؟ VRE. Environmental services. Cleaning principles. We should talk about cleaning principles if we are talking about خدمة البيئة أو نظافة البيئة أو environmental hygiene. We should talk about cleaning principle. Cleaning principles is the key to cleaning and disinfection environment surface is to use friction to physically remove visible dirt, organic material, debris, and 3P removing microorganisms. Okay, high touch and other surfaces, يعني high touch areas and non-high touch areas. The cleaning of environmental surfaces is divided into 2 categories too, based on how frequently these items need to be, how frequently these items are touched, and based on the associated risk of the infection transmission from these areas. High-touch surfaces or items need to be cleaned frequently because of the high degree of handling and the risk of cross-contamination from these areas. Surfaces and items that do not need to be cleaned frequently are those that not handled or less likely to be a source of infection. High-touch items require the frequent cleaning, as we say, including, but are not limited to what mean high frequently touch areas examples: medical equipment, knobs, handles, X-ray machines, cardiac monitors, blood pressure cuffs, doorknobs, bed rails, televisions control, nurse calling bells, telephones, computer keyboard. These consider as high frequent touch areas, and those need to be cleaned more frequently because they have, of course, microorganisms on them due to the hand contact frequent time. Many of these surfaces, such as controls or medical equipment, are cleaned after each patient use, which is really, really preferably. This is a recommendation. Yeah, this is a standard. The manufacturer recommended procedures and chemical for cleaning these surfaces must be followed. Manufacturer recommendations must be followed. Non-adherence with the manufacturer instructions and use inappropriate cleaning agents may result in damage for some equipment. Therefore, please follow up the manufacturer recommendation with any equipment. For example, alcohol, disinfectant, maybe a blower or plastic viewer window not clear after wiping any glass material with alcohol agent. Alternatively, floors, walls, windows, curtains, lights, and ventilation grills usually need less frequent cleaning because those are low-touch surfaces. Okay, facilities should ensure these surfaces are cleaned routinely by establishing a schedule, creating and following procedure, and using effective cleaning agents. These surfaces must also be cleaned immediately when visibly are soiled. It is important to note that cleaning procedures and cleaning agents used in the environment surfaces usually differ from those whom are using for cleaning patient care equipment and instruments. Let's take them by areas. The environment, hospital environment, if we divide it into areas, let's take them zone by zone. First, patient zone. The area that we are caring about is the patient zone. We want to clear and clean the area from germs to avoid cross-contamination and possible infection, of course. So there are two zones of the care patient zone and the healthcare zone. يعني patient zone area هي ال patient zone near to the patient bed, and the surrounding patient bed is the healthcare zone. The patient zone consists of patient and his immediate surrounding. Okay, many high-touch surfaces are within the patient zone. That's why we care about this area. For example, patient room, the patient zone would be patient and the patient bed and the surrounding high-frequent touch surfaces. The patient zone can quickly become heavily soiled with patient's flora. Of course, if the patient zone is not properly cleaned, the contaminated surfaces can be a reservoir for microorganisms that are transmitted to the next individual, of course, contacting to this zone. At the same time, organisms outside of the patient zone are foreign organisms, and they might have a potential harmful or risk to patient area zone when they introduce to it. Although all other areas outside the patient zone fall under healthcare zone. So عندنا patient zone and healthcare zone. This include other surfaces and other patients and their individual patient zones. Cleaning procedures. Cleaning schedule أهم حاجة. The cleaning schedule and the process of the cleaning and follow up the cleaning protocol. These are the main things that you should follow with the cleaning and what the agents they used in the cleaning process. For example, the agents, the dilution, the time contact, how long was the detergent to have been mixed, how frequent they clean the mops and the housekeeping carts. All these kind of things has to be checked with cleaning procedures. Cleaning schedule and procedures progress. From the list, how we clean, from the least soil area to the most soil area. So we clean from outside patient zone until we reach patient zone, because we consider patient zone as the heavily soiled area. And second, from the high to the low, from the top to the bottom. This is how we clean vertically, from the top to the bottom, from the lowest pathogen count to the highest pathogen count. Okay, routine cleaning is necessary to maintain a basic standard. Routine cleaning is a basic standard. It's not something extra or something or luxury thing. It's a basic standard of cleanness. طيب? Procedures must be effective, consistent, and thorough to ensure cleaning process is done effectively. Dust contains fungal spores, as we know, such as Aspergillus, so which may cause a vital infection, especially in immunocompromised individuals. Therefore, it is important to minimize the air and try to use a wet technique for mopping the dust in the rooms. Environmental service personnel should partner with the nursing staff to move any immunocompromised patient away from the dust-creating activities. Dust-creating activity, including dusting, vacuuming, and waxing, and buffing floors. If you want to know which activities that increase the dust level in the area, those are the activities, and immunocompromised patients should be avoided and away from these activities. High efficiency power filters, اللي هي HEPA filters, is a vacuum cleaners collect the dust produced by machines. And if the activity is outside the patient room, the environment service should close the doors to the patient room prior to start any activity. Cleaning methods and procedures vary among healthcare settings. Therefore, each institution must establish a written policy and procedure through a multidisciplinary team approach to cover all the aspects that they consider, to cover all the risks that they think about. So it's good always to have a multidisciplinary team approach to identify and establish a cleaning protocol procedure. The multidisciplinary team should include الEF الVC اللي هم Environment Services Team, Infection Prevention Control, Nursing, Administration, Clinical Engineering and Material Management, Pharmacy, Information System and Food Services too. Infection Control Team can help to educate the environment personnel team and other staff, offer evidence on cleaning procedure schedule, provide expertise of cleaning agents, assist in written policy procedure, participate in performing improvement activity with them as well. Every facility should also develop a performance improvement activity to measure the effectiveness of its cleaning program and how it is it effective, it's not effective, is the environment source of infection or not, and etc. Cleaning agents, environmental services team and infection control team and other individuals responsible for selecting, purchasing, and educating other on the use of cleaning products such should have through understanding of the difference between and the uses of these chemicals. Disinfectants and detergents, هذا النوعين, must be used according to the manufacturer instruction on the label. Dilution, contact time, where to store, shelf life, compatibility, all these kind of things. Approved and registered, the disinfectant and detergent should be approved and registered through Environmental Protection Agency, اللي هي EPA, and Food Drug Administration, FDA. Fresh tap water should be used to dilute the disinfectant or detergent, usually, and containers for the cleaning agent must be labeled in accordance with the regulatory requirements. The requirements are chemical content and the name, expiration date of the agent. Okay, all this data should be clear written outside the dilution container. Cleaning agents, a large number of disinfectants registered by the EPA, and a large of them also acceptable for routine decontamination of environment. EPA registered quat are the most frequently selected item for cleaning environmental surfaces. We know quats. So occasionally, phenols have been used when encouraging greater contamination. Whenever you have spillage or not spillage, whenever you have greater contamination, you should select phenols instead of quats, such as in operating rooms. Bleach 1 to 10 dilution has gained wide acceptance as an effective use in expensive instead of expensive disinfectant. For what? For blood spillage and norovirus infection and C. difficile infection too. The EPA also has a list of sporicidal disinfections effective against C. difficile, and remember, quats and phenols are not sporicidals. So quats and phenols cannot be used with C. difficile infected patients. Disinfectants. Disinfectants are divided into two, intermediate and high level, and low actually. Three divisions. Low level disinfections kills most vegetative bacteria, some fungi, and some viruses within the contact time that is recommended from the manufacturer, whereas intermediate level of disinfection is in addition to kill vegetative bacteria, it kills also mycobacteria, most of fungi, most of viruses, and some bacterial spores. This is the intermediate. However, the high-level disinfection kills the spores as well as all forms of microorganisms. This action time needs the spectrum of disinfectants vary. In general, low and intermediate level disinfection are used for cleaning the surfaces. Okay, and they are reviewed by the EPA, whereas high-level disinfection or sterilants, they are used for medical equipments and antiseptic also. Detergents. So here is the difference between detergents and disinfectants. Detergents are more environmentally friendly, non-toxic, produce less offense odor, and unlikely to trigger an adverse respiratory reactions. It doesn't cause any cough or it doesn't harm. It's not harm for asthma patients and cost less than disinfectants. Of course, they cost less. Studies show that floors cleaned with detergents do not increase the risk of HAIs, meaning the floors can be cleaned with detergents. Unfortunately, detergents do not have the same high effective as disinfectants on microorganisms. So they are less effective on microorganisms. Detergent solutions and also become easily contaminated. That's one of the disadvantages of them. Therefore, the CDC recommend using disinfectants for cleaning horizontal surfaces, especially high-touch surfaces in patients' care, on medical equipment and in isolation rooms and during the outbreaks. CDC, they recommend disinfections instead of detergents in these circumstances. Detergents may be used on floors except in isolation rooms. hydroperoxide يعني عندنا disinfectant, detergent, hydroperoxide. Hydroperoxide falls into the lowest toxicity risk level, very low toxic level. It is non-corrosive, compatible with most surfaces, releases a minimum chemical odor, require only one step to clean and disinfect, and can be purchased in wipes or in liquid. But disadvantage is expensive than quat and bleach. It is more expensive than quat and bleach. Special circumstances. Now, how you deal with your environment and in your healthcare facility in certain cases. So I believe I labeled 9 or maybe more situations or circumstances that I mentioned clearly what you need to do in these cases, because those cases whom can cause a risk, can cause blood-borne pathogen transmission infection. Those cases can cause outbreaks. Those cases can raise a risk of infection and cross-contamination. So I listed them as a special circumstances. First, in the circumstance of blood and body fluid exposure or spillage. If the spill is small, it can be cleaned and disinfected in one step by pouring the disinfectant directly on the spill and clean up after the appropriate contact time is completed or the disinfectant has been reached as per manufacturer recommendation of the disinfectant, okay? What if the spill is large amount and involve a higher concentration of microorganisms? What we should do, we should add absorbent material that can be on the place over the spill until the fluid is absorbed into the material. Then a disinfectant solution can be poured over the spill and absorb the material until both are thoroughly soaked in the disinfectant for the designed contact time. Then the spill can be cleaned and absorbent powder which absorb the liquid recommended to be by using a biological hazard spill kit. Okay. Next case is if you have a C. difficile infection case. C. difficile emerge as a major pathogen of healthcare-associated diarrhea and colitis. Multiple outbreaks caused by a strain with a high mortality rate have been reported from C. difficile infection. The organism produced spores in feces. Surfaces contaminated with the feces become a potential reservoir of the spores, which can survive in the environment for 5 months. So chlorine-contained component and disinfectant consist of hydrogen peroxide component can be used to clean contaminated environments. Researchers have recently shown that use of ultraviolet light and hydrogen peroxide vapors after physical cleaning. After physical cleaning, not before, because always disinfection or disinfection, decontamination cannot be successful without prior physical cleaning, okay, will further reduce C. difficile from the environment, including from unsafe supplies. Third case is diarrhea outbreak. For example, if you have a norovirus outbreak in a ward, what you will do, hand hygiene is the key preventing transmission of microorganisms that cause gastroenteritis, okay? Because most of these germs are transmitted from feces to the hands after the toilet use, and when we touch all the surfaces become contaminated. So therefore, the infection will be transmission. However, when the environment is heavily contaminated, especially during diarrhea outbreak, hand hygiene alone is not adequate. So extra effort should be done through a clean environment. How we should clean environment, because norovirus is leading to cause gastroenteritis and responsible for multiple outbreaks in healthcare facilities. Using UV light or hydrogen peroxide vapor, need steam cleaning the furniture as well and carpeting. Using these novel methods after physical cleaning help ensure the environment free of diarrheal pathogens. Number 4, Mycobacteria tuberculosis is initially more resistant to disinfection. TB is resistant to disinfection than most of the other organisms. Therefore, it is important to clean surfaces possibly contaminated with mycobacteria, such as Mycobacteria tuberculosis, with an EPA-registered tuberculosis disinfectant. Disinfectant not tested against the organism, considered not effective. The disinfectant should be tested against the organism that you are trying to clean to make sure it's effective to remove that microorganism. Many tuberculosis disinfectants require 5 to 10 minutes contact time to be effective. The manufacturer instruction for use must be followed. Nurseries area. Basins, incubators, scales, and other equipment in nurseries must be cleaned on routine schedule and when the patient transfer or discharge. Infants must be removed from their beds before cleaning and disinfection, and not return to the bed until the surface is completely dry. Usually we use quat in infants areas environmental cleaning, because there is an association between the excessive use of phenolic disinfectant and the newborns. So phenols are not recommended for use in nurseries due to the odor of the phenols, of course. Number 6, CGD virus. The agents of CGD are resistant to commonly used disinfectant, just like the TB bacteria. The most likely areas where environmental surfaces might become contaminated with the CGD virus in the operating room, autopsy area, and clinical laboratory. These are the main risk of CGD virus areas and need thoroughly cleaning and disinfection and special protocol to ensure the area is safe for staff. If unprotected surface become contaminated with central nervous system tissue or cerebrospinal fluid containing a CGD virus, the body fluid must first be removed using absorbent material. Then the surface must be flooded with the sodium hypochlorite solution or bleach. And after exposing the surface to the chemical for 30 to 60 minutes, the solution must be removed using additional absorbent material. And after that, you remove all these materials into biohazard waste container, and finally clean the surface with water thoroughly rinsed. Number 7, severe acute respiratory syndrome, SARS, or coronavirus. So SARS is caused by coronavirus. Studies on the virus have been shown that it can survive in feces and urine for 2 days. EPA registered viral disinfectant and or bleach solution can kill the virus, of course, because the environment of the patient with SARS is heavily contaminated. Surfaces must be thoroughly cleaned daily and upon discharge. Personnel who perform these cleaning tasks must follow isolation precautions, must wear a mask, a gown, gloves, and appropriate eye protection wear. Number 8, MDROs and isolation rooms. Multi-drug resistance, including MRSA or CRE, have not developed resistance to disinfectant. So no single disinfectant has been specified for use for MDROs because this organisms, they need physical cleaning, hard physical cleaning. Contact precaution must be followed for those patients and during a cleaning process. Cleaning tasks with intermediate level disinfection like phenols and chlorine for infected patients. Privacy curtains must be changed after the patient is discharged. Bed bugs. Infected patients and visitors and healthcare workers can bring bed bugs into healthcare facilities through their clothing or their personal belongings, and in assistive devices such as wheelchairs and walkers. Indications of bed bugs include bites on the individuals, so they are recognizable. Patients may inform their caretakers that they have bed bugs, so the healthcare worker can contain the situation and deal with it properly. If not detected early, the bugs may invade the hospital linen and raised in the cracks and create and the furnitures and the matrix and bed frames and chairs and tables. And this is really uncontrollable situation. Bed bugs can survive for years without feeding, so they are very, very high risk pathogens. If bed bugs are suspected in a patient, they must examined and personal belongings should be placed in a plastic bag that are tied securely and closed away from the any open area. Reusable equipment such as wheelchair and walkers should be thoroughly cleaned for heavy and resistant infections. Insecticides should be used in this case. Healthcare personnel should wear protective gown and gloves while providing a care or when decontaminating these areas. Infected furniture and rooms items that need to be contained and discarded, apply insecticides. Mattresses and pillows. Actually, in the hospital setting or healthcare setting, mattresses and pillows could be a source of cross-contamination. So if those pillows and mattress covers are made of moisture-resistant material and they are easily to be cleaned, then that's fine. Fabric cover are not recommended. As we know, if they are used, they must be laundried between patients. Mattress and pillows with cracks, tears, or heavy stains must be immediately discarded. Mattress and pillows must be cleaned and disinfected with EPA-registered disinfectant and according to the manufacturer recommendations between each patient and when visibly soiled. Waste management. Waste is collected from all areas at least daily. But if there is a large volume of the waste has been generated in the facility, more frequent pickup should be scheduled. Filled waste containers must be emptied, and these containers must be routinely cleaned and disinfected. There are separate containers for biohazards and non-biohazard waste, chemical waste, radioactive waste, regular waste, and recyclable waste. All these wastes should be characterized. Pest control. The persistence of flies and mosquitoes, ants, and mice, rats in the facility indicate an unhealthy environment and in a healthcare facility. The key to minimize pests in any facility is very simple. Actually, is to eliminate food sources because they follow the food whenever it is. So eliminate the food sources eliminate areas for nets and that areas harbor any animals or rats, install tightly fitting screens on windows and doors, sealing doors tightly, and apply pesticides with a pest control company, use a pesticide solution routinely, monthly schedule. This all will aid the pest control in the facility. Food should not be left open and out in open area. Eating areas should be selected and cleaned frequently. Food waste should be discarded with sealed container and locked and closed. Bed bugs control is more costly than the other type of pests. يعني البيد bugs is the highest level of pest control threatening or risk. The examiner for the facility for the pest control need to make multiple visits actually and use variety of chemicals and expensive high heating devices whenever needed to control the pests in the facility. Environmental gram-negative bacilli, Pseudomonas species, Acinetobacter species, and other glucose non-fermentative bacilli are common cause of healthcare-associated infections, especially nosocomial infection. They are particularly notable for their authentic antimicrobial resistance, so they are notable. Acinetobacter infection have played an increasingly role mainly in hospital outbreaks and endemics infections, especially when infection prevention measures are not followed. So recently, Acinetobacter infection, is the trend of the all microorganisms infections around the area. The functions and as opportunities in hospitalized patients compromised by age, surgery, chemotherapy, and device use, meaning these bacteria, this gram-negative bacilli, is targeting the age group, certain age group, post-surgery patients, chemotherapy patients, and device-associated infections patients. Hospital environment recommendations. In general, each unit has an environment cleaning, disinfection schedule. So the schedule here is very important to record the responsibility of the responsible worker and what agent has been used and what method of cleaning has been used, and the environment service intend to be cleaned. So specify the area, the person, the method of cleaning, the agent have been used in this schedule. This will make the monitoring of the process very useful. Cleaning agents and disinfectants are consistent with hospital policy and used in the correct method according to the manufacturer recommendation, including dilution and contact time. Dilution contact time is very important. There are a separate clean and dirty utility room in each patient care area. Housekeepers are trained on hand hygiene, use PPE, methods of cleaning, and proper and safe mixing of chemicals too. So only experienced housekeeping staff are allowed in critical care units. Hospital environments. Lockers and cabinets are regularly cleaned, dry, and free of dusts. These are the general recommendation how to maintain an environment of any healthcare setting safe. Bedside curtains are clean, free of stain, and changed regularly, and when visibly contaminated, and after patient isolation patient discharge. Terminal cleaning process is done by using ultraviolet machine or fog machine when indicated. Terminal cleaning process after discontinuing of isolation is supervised by an in-charge nurse, and in case of outbreak, by infection prevention and control practitioner. Biological spill kits are available in all areas that have the risk of blood and body fluid splash or exposure, and healthcare workers are capable of using them properly. Routine environmental microbiological cultures for air and water and environmental surfaces are not recommended routinely. However, only environmental samples is conducted when indicated and approved by infection prevention and control team. There is a specific area for routine schedule cleaning disinfection of incubators for the infants, or when required by the using of approved MOH disinfectant and based on manufacturer recommendation. Hydrotherapy equipment, such as in the, hydrotherapy equipments used in burn units, physiotherapy units are drained and cleaned with disinfectant after each patient use. Flowers, plants are acceptable in immunocompetent patients. However, they are prohibited in immunocompromised patients. Medical equipment are clean, disinfect properly as per hospital policy and following manufacturer recommendation in regards to frequency, recommended products, dilution, contact time, and methodology. This is the end of the topic. Thank you very much. If you have any question, please ask. Still we have one topic. لا ما تغيرت، أنا نفس السبيكر. You're welcome. عبد المجيد, you're welcome. Five minutes break. Let me take a sip of water and we will move on to the finest topic. It's very fine. It won't take time from us. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome, everyone. Ahlan. Thanks for continuous listening. today. This is my latest topic today. Just give me 1 minute. Sorry, guys. This is the latest topic today with regards respiratory hygiene and cough etiquette. It is very simple, very little, basic. Outline we are going to discuss what is respiratory hygiene and cough etiquette. What is that concept? And we're going to talk about respiratory hygiene, cough etiquette in healthcare settings, as this is what thing we need to mainly focus on and emphasize in our job. So what is respiratory hygiene, respiratory hygiene and cough etiquette? These are infection prevention measures designed to limit the transmission of respiratory pathogens spread by droplet and airborne routes. As we remember from the infection chain, that the mode of transmission are 3 types: contact, direct and indirect, airborne, and finally droplet. So therefore, we want to break the chain of infection from this side by preventing the spread of droplet and airborne from these routes. The strategies targeted all patients and all healthcare workers, combining patients, but also apply to anyone with signs and symptoms of illness, anyone with signs and symptoms of illness, of airborne disease or droplet disease, any respiratory illnesses, diseases. Patients should follow, or individuals in general should follow the respiratory hygiene and cough etiquette. So they were added to standard precaution in 2007 and emphasize 2 key elements by the CDC. So by the CDC, the respiratory hygiene and cough etiquette have been added as one standard, one element in standard precautions. To emphasize 2 key elements. 1, to implement measures to prevent the spread of respiratory infections from anyone in healthcare settings with signs and symptoms. Post-sign at entrance, asking patients with symptoms and respiratory infections to cover their mouth and nose when coughing and sneezing. Use tissue and throw them away immediately. Wash your hands or use a hand sanitizer every time you touch your mouth or nose. Okay, this is number 1. Provide tissue and no touch practice to their disposal. No touch. Provide resources for performing hand hygiene in the point of care, in the point of entrance, in the point of triage, in the point of clinic, in order to also to the waiting area. Offer masks to symptomatic patients when they enter the hospital or dental setting or anywhere. Provide space and encourage symptomatic patient to sit as far anyway from those as possible. Facilitate may wish to place these patients in a separated waiting area if available while waiting for their care. So separation, cough etiquette, hand hygiene, social distance, masking, all these perspectives are respiratory hygiene and cough etiquette elements. Second, to educate on the importance of prevention measures when examining and caring for patients with signs and symptoms for respiratory infections. Respiratory hygiene, cough etiquette in healthcare settings to prevent the transmission of all respiratory infections in healthcare settings, including influenza. Especially now we are in influenza season. Respiratory hygiene and cough etiquette is quite important, guys, and you need to emphasize this in your facilities. The following infection control measure should be implemented at the first point of contact with potentially infected person. Anyone can remember which area is this? The visual triad. The visual triad area is very, very effective in enhancing respiratory hygiene and cough etiquette because it can select which patient is with signs and symptoms by scoring them immediately. It can supply and support the patient with mask and hand rub and tissue if needed. It can guide the patient to sit in separated waiting area with patient with illnesses, respiratory illnesses. So first point of contact with potential infected person is very, very important to eliminate the source of infection and control the spread of infection. Also, they should be incorporate into infection control practices as one component of standard precautions. Components include included under respiratory hygiene and cough etiquette. First is the visual alert. So post-visual alert, an appropriate language or bilanguage at the entrance of the outpatient facility, emergency department, physician's office, outpatient clinics, waiting areas as well. Instruct patients and persons who accompany them, like family and friends, to inform the healthcare personnel by symptoms, respiratory infection when they first register, when they first meet the first line. It's good to educate the visitors, the patients, the families to alert the first liners that they have signs and symptoms of respiratory illnesses, and to practice respiratory hygiene and cough etiquette. Second, respiratory hygiene, cough etiquette. The following measures to contain respiratory secretions are recommended for all individuals with signs and symptoms of respiratory infections. Cover your mouth and nose, as we said before, and it's all written in one poster. I will share it with you at the end. I think you know it. Cover your mouth and nose with the tissue when you cough and sneeze. If you don't have tissue, use your elbow, of course, cough in your elbow. Use in the nearest waist, dispose this tissue and do hand hygiene, perform hand hygiene, hand wash with non-antimicrobial soap and water, or alcohol hand rub is good, or antiseptic hand wash after having contact with respiratory secretions and contaminated objects or materials. This is the poster that we all know. I believe you all hang it in your areas. Stop the spread of germs that makes you and others sick. Cover your cough. As here we said, use tissue. Instead, if you don't have tissue, use your elbow. Discard the tissue while you use it. Place on a mask. Perform hand hygiene. Either hand washing or hand rubbing. Healthcare facilities should ensure the availability of materials for adhering to respiratory hygiene and cough etiquette in waiting areas for patients and visitors. Provide tissues and no-touch for use tissue disposal. Provide located dispensers of alcohol hand rub. Make them accessible, make them visible. Sign beside them, post beside them the hand rubbing technique, the hand washing technique as well, where sinks are available. Ensure that the supplies of hand washing are available, such as soaps, towels, hot and cold water are always available. Number 3, masking and separation of persons with respiratory symptoms. During periods of increased respiratory infections activity in the community, such as influenza season or COVID-19 time, when there is an increase of illnesses in schools, workstations, or in community by persons, offer masks immediately to those whom are coughing. Offer masks to those whom coughing and sneezing. So masking and separation, social distance of persons is very important. Either procedures masking, like for example with ear loops or the ties, all types of masking is okay. But of course not to use N95 because we are not in airborne situations, we are in droplet situation, which all what we need is surgical mask. Droplet precaution. Advise healthcare personnel to observe droplet precaution carefully for droplet precaution patients in the facility by wearing the surgical mask or procedure mask if they go in close contact with the patient, like 3 feet apart. In addition to standard precaution when examining a patient with symptoms or respiratory infection, particularly if the patient is fever or the fever is present. These precautions should be maintained until it determined that the cause of symptoms is not an infectious agent that requires an isolation precaution. So as we know, this is the droplet precaution signage. All what requires is a surgical mask. Bilingual. Practice hand hygiene. Wear a surgical mask. That's all. I think that's the end of the session. Thank you, everyone. Ask me if you have any question. I believe this is a very basic topic. Any questions so far? Thank you very much. أهلا وسهلا يا فارس. صحيح الفرز البصري مرة مهمة. لأن جزء عبد المجيد جزء من ال outbreak management أو جزء من ال infection prevention risk strategies اللي هو early detection of the infection. فأنت من ال early detection من ال first triage تعرف you will detect the infection so you will isolate the source. بعد كذا you are fine. أهلا وسهلا ميعاد. الله يعافيكي. شكرا جزيلا. I'll keep 10 minutes break and then Dr. Hiba will join, I believe. Dr. Hiba will continue guys with you guys the course for today and tomorrow Dr. Hiba only. شخصيا تشرفت فيكم. شخصيا استمتعت بأداء المحاضرات. أتمنى أني وفقت. أتمنى أن أنتم استفدتوا لأن المواضيع جدا كبيرة صراحة. أهلا وسهلا. شكرا. المواضيع جدا كبيرة ولا أبغى أعطيكم شيء أكثر من اللي تحتاجونه. يعني حاولت أخليها على الهيلث كير سيتنجز. بركز على prevention والخطر وين والبريفنشن لأن أنا ما أبغى الانفكشن تنتشر. هذا أهم شيء. يس تشرفت فيكم جميعا. شكرا على كلامكم. شكرا على اللي شكروني بالشات على حضوركم ووجودكم. إن شاء الله نتواصل في المستقبل ودائما. 10 دقائق. الله يسعدكم وتجيكم الدكتورة هبة. Thank you so much. Pleasure to meet you all. And take care and stay safe. في أمان الله.
Hello, السلام عليكم. Hello everyone. Good evening. عاملين إيه؟ أهلا بيكم أهلا. عبد المجيد، فارس، ابتسام، عاملين إيه؟ كويسين؟ يلا نبدأ، جاهزين؟ ولا ستيل بريك يا جدعان؟ أهلا عبد الرزاق، أهلا عبد المجيد، جاهزين؟ طب تمام، حلو قوي. هنتكلم عن National Patient Safety Goals. عبد الرزاق، مباراة إيه؟ How many goals we have in patient safety? National or international goals? Anybody knows about it? But we will finish after يا عبد الرزاق. Yes, sure. It will be simple and you will interest إن شاء الله. How many goals we have in patient safety? National or international patient safety goals? We'll start. The national patient safety goals were established in 2002 to help accredited organization address a specific area of concern in regard to patient safety. The first set of national patient safety goals was effective from January 2003. أهداف سلامة المرضى الوطنية هي اتعملت أصلا من بدايتها كانت في 2002 و effective أو طبقوها على المستشفيات من يناير 2003. اوكي. و هي منظمة زي سباهي كده عندنا في السعودية، اسمها Joint Commission، هي اللي عملت National Patient Safety Goals and International Patient Safety Goals also. The Joint Commission determined the highest priority patient safety issue. شافوا إن أولوية اللي بنحتاجها للمرضى، أولوية السلامة للمرضى including national safety goals from input from practitioners, provider organization, purchase, consumer groups, and other stakeholders. أول حاجة هنبدأ بيها طبعا ودي معروفة national or international patient identification. إزاي أتعرف على المريض أول ما يجي عندي؟ أهم نقطة أعرف إن المستشفى دي مطبقة سلامة المرضى ولا لأ من أول ما المريض يدخل بيتعرفوا على المريض صح ولا لأ. طريقة تعرفهم على المريض صحيحة ولا لأ. من هنا هعرف المستشفى دي مطبقة ال patient safety well or not. The first goal improve the accuracy of patient identification. إن أنا أحسن من إن أنا إزاي أتعرف على المريض، التعرف الصحيح للمريض. Use at least 2 patient identification when providing care, treatment and service. عشان أتعرف على مريض لازم يبقى عندي على الأقل معرفين أعرف بيهم المريض، أهم حاجة طبعًا الاسم ورقم هوية أو رقم الملف أو رقم السجل بتاع المريض بتاعي، أو لو في رقم ID يعني خاص بالمستشفى ليه فده أفضل كمان. الاسم بيبقى ثلاثي المفروض، لازم أكتب الاسم بتاعي ثلاثي أسجله، والID أو رقم هوية أو رقم أحيانًا بيطلبوا طبعًا address sometimes في طبعًا هيكون في بعض أيوه السعودي 4 yes excellent عبد المجيد I know. كنت لسه هاقول يعني patient identification في السعودية بيكون رباعي، الاسم رباعي لأن فعلًا أنا شُفت بعيني رُحت مستشفى في قسم العمليات لقيت مريضة بنفس الاسم الثلاثي فعلًا نفس الاسم، مريضتين عاملين عملية في نفس الوقت ونفس الدكتور سبحان الله، لقيت ال3 أسماء، فطبعًا حصل OVR في الموضوع، طب المفروض نعمل إيه مُعرِّف تاني غير الID. أي relative هييجي في المستشفى مش هيقعد يسأل بالID هيسأل باسم المريض. فالتمريض حصل عندهم شوية ربكة في الموضوع ده بس اتحلت يعني بعد كده نزّلنا يعني زي ميمو إن هو المفروض يبقى رباعي زي ما بنتّبعه هنا النظام في السعودية يعني. This applies to ambulatory, assisted living, community, behavioral health and human service, critical access hospital, home care, hospitals, laboratory, nursing care center, office-based surgery. Okay. Improve communication. لازم يبقى في تحسين في التواصل مع الcaregiver giver أو الhealth care worker between of them يعني الطبيب مع الممرضة لازم الcommunication يبقى فعّال، التواصل فعّال بين الstaff ويكون verbal يكون مكتوب. Improve the effectiveness of communication among caregivers. Report critical result of test and diagnostic procedure on a timely basis. This goals applies to critical access hospital and laboratory. The third goal about medication safety. Improve the safety of using medication. تحسين السلامة في استخدام الأدوية بتاعتنا. How? Medication safety label all medication container and other solution on and off the trial field in pre-operative and other procedures setting. يعني إحنا دلوقتي عشان الميديكيشن سيفتي أو إن أنا أستخدم الأدوية بتاعتي بأمن وسلام ويبقى صح الطريقة بتاعتها إن إحنا نعمل labels لكل الأدوية بتاعتنا وخاصة look alike و sound like. في بعض الأدوية بتبقى متشابهة في الاسم، فممكن يعمل لنا خلل إحنا وبنصرف الوصفة بتاعتنا. فمهم جدًا إن إحنا نبقى عاملين label بcolors معيّنة، مثلًا للsound like نعملها باللون الأحمر عشان نبقى عارفين إن الأدوية دي، ونخلّيها بعيدة عن بعض كمان، ما تبقاش في نفس الصف، في نفس الترتيب، خاصةً sound like وlook alike، لأن بيحصل كتير أخطاء وهُم بيصرفوا الوصفة، تلاقي الpharmacist ممكن الدوا مشابه لبعض look alike يعني شبه بعض، فممكن يعمل خلل أو دربكة كبيرة أو خطر كبير harm. It will be sentinel event also. Yes, لازم medication also. And we should make label in all container also. Like and other solution on and off the trial field in perioperative and other procedure setting. Medication safety also reduce the likelihood of patient harm associated with the use of anticoagulant therapy. These goals also apply to ambulatory, critical access hospital, and hospital nursing care center. This is a third national patient safety goal. Maintain and communicate accurate patient medication information. لازم أطابق برضو الانفورميشن بتاعة المريض مع الوصفة بتاعتي مع التحضير، لازم يبقى مطابق كلهم. أشوف الجرعات صح، ويا ريت الأفضل في الفارماسي يبقى فيه دبل تشيك، لأن ممكن أنا أكون جهزت الوصفة والجرعة وكل حاجة، بس تبقى فيه مثلا حدث نقص في حاجة معينة، فلما يكون فيه دبل تشيك يقدر my friend he can maintain this event. These goals also apply to ambulatory assisted living community, behavioral health and human service, critical access hospital, home care hospital, nursing care center, and office-based surgery. Clinical alarm safety. This goal, the number 6, is for reduce patient harm associated with clinical alarm system. How? Improve the safety of clinical alarm safety. And this goal also apply to critical access hospital and hospitals. Healthcare associated infection، دي الأمراض المتعلقة بالمستشفيات. Reduce the risk of healthcare associated infection. This goal 7. Healthcare associated infection comply with either the current Center for Disease Control and Prevention, this CDC, hand hygiene guideline, or the current World Health Organization hand hygiene guideline. These goals also apply to ambulatory, assisted living community, behavioral health and human service, critical access hospital, home care, hospital, laboratory, nursing care center, office-based surgery. And here it's so important to also reduce falls. Reduce the risk of patient harm resulting from fall. These goals apply to assist living community and home care, nursing care center. The goals 14 about pressure ulcer, prevent health care associated pressure ulcer, cubitus ulcer. This applies also in nursing care center. Access and periodically reassess each patient and resident risk for developing a pressure ulcer and take action to address any identified risk. Risk assessment. The organization identify safety risk inherent in its patient population. Reduce the risk for suicide. This goals also applies to behavior health and human service, critical access hospital and hospital. Risk assessment. National Patient Safety Goal number 15, identify risk associated with home oxygen therapy, such as home fires, apply to home care. Universal protocol for preventing wrong site, wrong procedure, wrong person surgery. This conduct pre-procedures, verification process. This all before any procedure. Conduct. This apply in ambulatory, critical access hospital and hospital office-based surgery. The second one of this one, mark the procedure site. It's so important. The timeout is performed before the procedure also. Just a second, I will open this all slide again and I will يعني هشرحه بالتفصيل الحاجات دي كلها. احنا بس نشوف ايه هي الناشونال بيشنت سيفتي جولز and each one هنشرحه بالتفصيل. A timeout is performed before the procedure. This apply to ambulatory, critical access hospital office-based surgery. This all is the national patient safety goals. Like you see, it's 15 national patient safety goals, and we have only 6 in international patient safety goals. we will talk about the both of them. This one already I talk about it. Now we will talk about how to improve communication. ازاي نقدر نحسن التواصل بين التمريض او بين health care giver او الاقسام مع بعض. ممكن حد يقول لي افكار مثلا او ازاي نقدر نحسن من التواصل بين الاقسام وبعضها، بين الهيلث كير جيفر، بين الاطباء كلهم، even مثلا دكتور عايز يكتب او عايز يعمل مثلا وصفة معينة، فالمفروض التواصل برضو يبقى ازاي مع الفارماسيست او النيرسينج. عايز ف I want to know how we can improve communication. Did you know about it? Improve communication between healthcare giver. حد يقول لي مثلا ازاي اقدر احسن التواصل بين الاقسام وبعضها، بين الهيلث كير جيفر. Hello, anybody here? How we can improve communication between caregivers and departments, between departments. It's so important when we want to write prescription, when we give order from the doctors to nurses. Hello. تحسين التواصل بين الأقسام، إن إحنا لازم الدكتور وهو مثلا أو health care giver he want contact with other department, he should أول حاجة إن هو يعرف بنفسه ويقول إن هو من أي قسم، مثلا يقول الطلب اللي هو عايزه، مثلا لو عايز طلب أشعة، طلب تحليل لمريض معين، يقول المريض اسمه كامل ويقول رقم الملف ويقول ايه الطلب اللي هو محتاجه. والطرف التاني برضو هو بياخد الأوردر يعيد عليه الكلام تاني ويسأله اسم المريض كذا كذا كذا، طيب رقم الملف كذا، عشان يأكد إن المعلومة وصلت صح. يبقى اسمه two side، والكوميونيكيشن يكون verbal. طيب لو في verbal ولازم يبقى نكتب كمان. يبقى مكتوب verbal written and verbal، خاصة لو في نتائج حرجة جدا بتحصل مثلا في الأقسام، في مريض مثلًا مثال طلع عنده جه عمل أشعة حادث، جه عمل أشعة طلع عنده كسر مضاعف مثلًا، فالمفروض إن إحنا نتصل بالدكتور على طول في نفس الوقت، عشان نبلّغه النتيجة اللي طلعت لينا، نقول له الاسم كامل زي ما قُلنا، ورقم الملف، وإن إحنا نسجّل النتايج الحرجة دي كلّها correctly. تمام؟ It should be written and verbal. Okay? Here about critical result of test and procedure on a timely basis. ولازم يبقى في نفس الوقت. التوقيت مهم جدًا. التوقيت مهم جدًا في إن إحنا لازم لمّا نبلّغ عن النتائج الحرجة اللي بتحصل يبقى on time. Okay? ميعاد الصوت ما كنتوش سامعين الصوت؟ sorry. طيب. تمام. طيب دلوقتي كله سامع؟ كله سامع الصوت؟ طيب يعني خلاص improve communication عرفتوا خلاص وصلت وسمعتوني فيه ولا لأ؟ طيب how to improve communication between the health caregiver and between department and when we will report any critical results. ما سمعتوش من هنا؟ طيب معلش. طيب هنا أنا قلت إن إحنا إزاي نحسن التواصل بين الأقسام. قلنا الحالات الحرجة لازم نبلغ نبلغ القسم التاني أو القسم المعني أو الطبيب، يكون verbal and written. verbal and written والطرف التاني برضو يعيد الكلام اللي قاله مثلا النيرس أو الدكتور اللي اتصل بيه، ونسجل الحاجات دي. وأي نتائج حرجة المفروض إن إحنا يبقى عندنا أصلا بوليسي من الأول، إزاي نكتب الإجراءات، يبقى فيه يعني مثلا إجراءات مكتوبة، وعشان نقدر نعمل إدارة للنتائج الحرجة دي والاختبارات وإجراءات التشخيص، نحدد فيها الإجراءات والوقت. الوقت مهم جدا إن يبقى فيه وقت مقبول، بيتوفر وقت مقبول بين الإبلاغ عن النتيجة وإجراءات التشخيص نفسها. تمام. و sometimes there is KPIs about it، إن إحنا الوقت اللي حصل بين إن إحنا بلغنا النتيجة للدكتور وإجراء التشخيص أو إجراء العلاج نفسه اللي اتخذناه بعد ما بلغنا عن النتائج الحرجة. تمام. مهم جدا improve communication between the healthcare giver. It should be written and verbal. ومكتوبة سياسات معينة ليها. Here about medication safety. Improve the safety of using medication. أنا اتكلمت عنه من شوية وقلت how to improve the safety of using medication. Somebody can tell me or about how we can make improve about the medication safety. Yes, excellent, Ali. And labels for all medication. يعني احنا اتكلمنا عن lookalike lookalike sound like واللازع. even in the surgery you should make label also for all your medication. And we should put also signs about the dangerous medications in the tube, and even the syringe, even the injection. الليبل هيكون حتى في العمليات الجراحية في القسم الجراحي كمان. ولما ننقل مثلا من دواء أو من علاج لكونتينر تاني معين، برضه لازم يبقى في label للcontainer التاني. الlabel مهم جدًا. في مشكلة حصلت قبل كده إن المستشفى بعد ما الدكتور بعد ما خلّص الجراحة والحاجات دي كلّها there is a syringe without any label. وما فيش communication كويس، يعني مثلًا المفروض إن الnurse تقول الnurse تبلّغ إن الsyringe ده أو الcontainer ده كانت بتاعة مثلًا حاجة معيّنة. مش ما فيش داعي إن أنا أذكر اسم الدوا والكلام ده، بس ما بلّغتش الممرضة التانية اللي معاها، والدوا مشابه لل المحاليل اللي إحنا المحاليل اللي بنعملها في with injections and like that. It's soft and white. Then the other nurse, she don't know about it and there is no any labels. وسابوا السرنجة دي في الدولاب من غير أي labels. فجت وزارة الصحة شيكت، كانت بتعمل مرور في نفس اليوم فلقت السرنجة دي. فالمفروض إيه الإجراء اللي يتخذ في الموضوع ده؟ It's so dangerous when we will not label all our medication, even in surgery room. They make reports for this hospital already and بقى في عملوا تقرير بسبب الحدث ده، وتم بقى طبعا السنتينل ايفنت also. ويتعمل لهم غرامة برضو. Okay, how we can improve the safety of using medication. We have questions here about للأسف احنا عندنا في المنشأة لما نستلم عينة يورين وبلاد في نفس لا لازم يبقى you should the first thing you should know about your procedure or policy and procedure in your hospital. تمام. أول حاجة إن احنا نبقى عارفين عن البوليسي والبروسيجر بتاعنا اللي بنتبعه في المستشفى بتاعتنا. ممكن المستشفى دي، بس هو الأفضل إن كل البوليسي والبروسيجرز now even the clinics or home care dental now also dental clinic they should know about the policy procedure for سباحي. Okay, but the label it should be in both container or not only one. يعني هما ممكن الاتنين بيبقى مع بعض مثلا في مغلف واحد أو حاجة زي كده. لأ، لازم كل عينة لوحدها يبقى both. yeah, no each one. يعني كل واحد لوحده يبقى فيها الليبل. كل عينة لوحدها يبقى فيه labels not the both of them. طب ما أنا ممكن مثلا أنا دلوقتي أنا أخدت both specimen and after minutes or after something I become busy. I can forget. صح؟ أنا ممكن أنسى. يعني أنا مثلا حطيت العينتين وشلتهم من بعض، بس حصل مثلا موقف أو زميلتي كلمتني أو حصل حاجة فخلاص نسيت. ممكن يتلخبط مع باقي العينات اللي موجودة عندي. لازم each one it should be there is labels. yes في أيوة في سباهي later on I can search for you, but yes, sure. Later I will or I will send to with مع المواد بتاعتي إن شاء الله أبعت لكم بإذن الله. Okay, label all medication like I told. ولما نعمل الليبلز برضو لازم يبقى فيه double check please. It's so important for all medications, all containers, or in the laboratory, in every department, we should have double check. Even when you have a request from the department, or even the patient, when give you the request for something, please check and ask your patients about it. Like the name, please, after you read, ask your patients, is this your name correctly? Okay. Here, how to reduce the likelihood of patient harm associated with the use of anticoagulant therapy. هنا العلاجات المضادة للجلطات، ازاي ان احنا نقلل احتمالية ان هم يصيبوا المرضى تصيب بالأدوية اللي بتاعت الجلطات نفسها يعني. how we will reduce it، إن إحنا نعمل تثقيف للمرضى نفسهم إزاي يقدروا يستخدموا الأدوية دي، يبقى عندهم برنامج معين إزاي نشرح لهم فيه الأدوية اللي إحنا بنقول عليها مضادة للتخثر أو الجلطات. يكون الدكتور والمريض قدامه ويشرح له طريقة الاستخدام للأدوية دي والمخاطر اللي تحصل ممكن لو زودنا عن الجرعة المحددة، والاحتياطات اللي المفروض يتخذوها، أو لما تحصل أي آثار جانبية إيه الاحتياطات اللي المفروض إنهم يتخذوها بالنسبة للعلاج المضاد للتخثر ده. أوكي، هنا عشان نحسن ونقلل من مخاطر الأحداث الدوائية الضارة برضو. We should have also evidence-based about it from in our hospital. لازم يبقى عندنا ممارسات بالأدلة موجودة في المستشفى، إزاي طريقة التعامل مع الأدوية الخاصة أو الأدوية العلاجات مضاد للتخثر وطريقة استخدامها والآثار الجانبية اللي ممكن تحصل، ده كله لازم نشرحه للمريض بتاعنا. عشان كده مهم جدا to reduce the likelihood of patient harmed about it. Okay, got it? We will go in other slide. Here, maintain and communicate accurate patient medication information also, like I told before. Here we will stop only 10 minutes to take break for prayer please. 10 دقايق بس للصلاة ونرجع نكمل السلايدات دي تاني. Okay. Only 10 minutes for break. Hello, السلام عليكم. Back again. We stop in this slide. Reduce patient harm associated with clinical alarm system. ده أنظمة الإنذار الإكلينيكي اللي المفروض بيبقى في المستشفى، بتهدف إن مقدم الرعاية الصحية بتاعتنا نقلل من الأخطار اللي بتحصل، وننبه الstaff لو في أي خطر حصل مثلًا. دي الحاجات اللي الجرس اللي بيبقى جنب السرير مثلًا. دي إشارات إنذار ب بتتحط إذا المريض حصل له أي خطر، بيبقى موجود عندنا الإنذار ده. ده نقلل برضه من أخطار العدوى المرتبطة بالرعاية الصحية، إن إحنا لازم ننفذ إرشادات نضافة الإيدين، إن إحنا نبقى عاملين برضه ال5 Whys. أي إرشادات بتكون من منظمة الصحة العالمية WHO أو الCDC، لازم الإجراءات بتاعتها تبقى متبعة. من هنا هنقلل الريسك للأمراض اللي بتبقى معدية أو اللي بتحصل من المستشفى أو المرتبطة بالرعاية الصحية نفسها. أوكي. ده اتكلمنا عنه، إن إحنا نقلل برضه من سقوط أو نتائج سقوط المرضى. هنا المستشفى بتحدد المخاطر السلامة الكامنة في عدد المرضى، إن إحنا نقلل من مخاطر الانتحار في مستشفيات النفسية. في research إن من 2 ل7 مريض بيفكروا في الانتحار أو بينتحروا already. ده مهم جدًا برضه الgoals دي about the suicide, reduce the risk of suicide. هو طبعًا أي مريض بيفكر في الانتحار أو ينتحر في الفترة اللي موجود فيها في المستشفى، دي بتبقى sentinel event على طول، ولازم يتم الإبلاغ عنها بشكل متكرر. يعني أول ما نحس إن مثلًا هو بيهدد بالانتحار برضه، ده هيكون sentinel event، لأن هو بيهدد يبقى خلاص هينتحر برضه، خلاص طالما فكر يبقى هينتحر. أوكي. وده برضه الuniversal protocol about wrong site, wrong procedure, wrong person surgery. it's so important إن إحنا نحدد السايت الصح والبروسيجر الصح للمريض الصح، وهنتكلم عنه بالتفصيل دلوقتي برضو في الانترناشونال، لأن أهم حاجة عندنا إحنا الانترناشونال patient safety goals for us يعني. new share. Now we'll talk about international patient safety goals. We have many versions about it, 2006, 2011, 2015 to 21. Also, it's developed by Joint Commission and National Patient Safety Goals adopted from the JCI. The version of 2006 is identify patient correctly, improve effective communication, improve the safety of high alert medication, eliminate wrong site, wrong patient, wrong procedure surgery, reduce the risk of health acute infection, reduce the risk of patient harm from falls. These are the 6 goals of international patient safety goals. This is the last version to 2017 until 2021. Identify patient correctly, also improve effective communication, improve the safety of high alert medication, ensure safe surgery, reduce the risk of healthcare associated infection, reduce the risk of patient harm resulting from fall. The international patient safety goals help the hospital address a specific area of concern in some of the most problematic area of the patient safety. Here also the poster of GCI about international safety goals. These goals also, it's so important in the hospital in Sibahi standard. There is standard ESR. All healthcare giver or الموظفين التمريض الأقسام الطبية, they should know about this international safety goals. يعني لما يمروا مثلا السباهي لازم كل الاستاف الميديكال ستاف يبقوا عارفين الانترناشونال patient safety goals. Standard international patient safety goals, the hospital develop and implement a process to improve accuracy of patient identification, twofold intent that to identify the individual as a person and to match the service or treatment to that individual. Here, as we see, how we can identify using 2 identifiers and name. Here they wrote in international 3, but for us here in Saudi Arabia 4. Before administrating where we can identify the patient before administering medication, before blood transfusion, before blood excretion, before any invasive procedure, transporting the patient, serving food, or offering any documentation printing like different type of appointment or prescription or reports. Here also there is other option to ID band. We can put when sometimes مثلا بيبقى في بعض المرضى ما نقدرش نحط لهم الاي باند دي في المستشفى في ايديهم. There is other place to put this ID band if not possible to wear on wrist. Here the situation, multiple IV line or there's burn, allergy or wound or dressing at both wrists, we can put in the ankle. Okay. In emergency or operative situation where clothing is removed and wrist ankle cannot be used, patient skin attached using see-through plastic adhesive film. If a limb is not available also, لو في مثلا الناس الديابيتك ما عندهم بتر ولا حاجة, attach the patient clothing using strapping on an area of the body which is visible. In the event of patient name not being known, أحيانا بيحصل إن مثلا مريض حادثة في الطريق وما معهوش أي حد معاه, وعايزين نتعرف على المريض ده. ما هو لازم أي مريض يدخل يبقى فيه identification. How we will identify this patient? He is accident, he don't have relative, he cannot, he's unconscious, مش في وعيه. إزاي هنعمل identify؟ with the ER مثلا number until the patient true identify is established. لازم يبقى عندنا رقم معين مثلا في emergency, وده بيبقى على حسب البروتوكول للمستشفى اللي موجودة كمان. يعني مثلا عندكم بوليسي معينة إن إزاي مريض مش في وعيه ولقيناه في الطريق وعايزين نعمل له مثلا إجراءات علاج ودخل المستشفى بس ما نعرفش عنه أي حاجة, فيبقى في بوليسي بالنسبة للموضوع ده. أو إن إحنا نبقى عاملين ER number لحد ما المريض يفوق أو نلاقي له الريلاتيف بتاعته أو حد يعرفه. The ID band should be worn in the dominant hand. Whenever possible, the patient should be asked to confirm and or read the detail on ID band, like double check. Okay. This, like we told, for unconscious or pediatric, refer ID band, verify information to family or watcher who know the patient. Identify in OBD when the patient is in OBD. The appointment slip will serve as an ID for the patient until he leave the OBD. It must 3, but here in Saudi Arabia, 4 full name and medical registration number. The patient ID band must be applied on admission to hospital. Here, like you asked before, who asked here about it, about this specimen container, should not be labeled in advance of receiving the specimen. Patient ID must be checked before completing the detail of the container. Sample to be labeled before leaving the patient bedside. Okay. The second goal about improve effective communication, like I told before, it should be verbal and written. The hospital develop and implement a process to improve the effectiveness of verbal and telephone communication among caregiver, reporting critical result or handover of communication. Here about verbal order, we will read this scenario. Order given in an emergency situation when spoken and when transcribed will use only approved abbreviation. Nurse A, the nurse number 1 or number A, write down the order. B will repeat back the order written by nurse A loudly. It should be loudly and clearly for the physician. And if confirmation given by the physician, the order can be carried out. Must be signed by the physician immediately after emergency is over or before the physician leave the unit. Here, there is scenario about injection adrenaline. The other example also, there is other example. Here, verbal telephone order will not be accepted for the following categories. Here, some categories. We will not accept the verbal telephone order, like chemotherapy, post-operative order, heparin weight-based order, hyper-elimination, intraspinal opioid order, patient care anesthesia, withdrawal of life support, initial personal order of narcotics. Here, we will not accept the verbal order telephone, okay? Also in panic value, the laboratory test results that are in critical value range which require urgent medical attention and possible immediate early medical intervention and may appear to be life-threatening and could be corrected by urgent intervention within 15 minutes. In IB and ER, the in charge should be informed if no response to the supervisor, clinician on duty, or the director on duty. No response in contacting the resident is not acceptable also. It should be escalated to the higher level. Okay, here about the panic value. It's all about it also. We have a script. Hello, this is staff name and ID number calling from, like I mentioned before, we should identify ourselves first, staff name and ID number, calling from the unit for laboratory. I have panic result, please write down the patient name and ID number. The panic result is, please read back to me the result I have given you. May I have your name and ID number? Thank you for your help. This is script about how we identify and how we will communicate between caregiver, health caregiver, okay? There is also radiology panic. We have here example. Level 1 result within 60 minutes. Life-threatening or would require an immediate change in patient management, finding tension pneumothoracic, evidence of ischemic bowel, intracerebral hemorrhage, leaking or ruptured aortic also. Sample statement in radiology, this find were communicated to doctor, full name and the time and the date. Handover process. we have important tools about how to communicate. Who knows about the SPAR? Somebody knows about SPAR tools and what we mean about SPAR? Hello? Did you know about SPAR and in each alphabet what we mean about it? It's written already in the slide. I means identify of patient, S situation, B background, A assessment and action, R recommendation. Identify patient name, age, medical registration number, ward team, situation, symptoms and problem, patient stability, concern, background, history of presentation, date of admission and diagnosis relevant, assessment list of a change condition. Okay, recommendation state what you would like to see done to the patient. Here there is a scenario also. Handover through 5B, patient information, patient date, present restriction, plan of care, and progress. The third goal, high alert medication. The hospital develop also and implement a process to improve the safety of high alert medication. High alert medication are drugs that bear heightened risk of causing significant patient harm when used in error. Contributing factor to medication confusion, incomplete knowledge of the drug name, newly available product or similar package or labeling, similar clinical use, and eligible prescription or misunderstanding during issue of verbal order. Here about high alert medication. The medication here we will see and the example of medications. Role of the nurse implementing the high alert medication. To double check, compare label, verify any calculation, assuring accuracy of medication pump program, medication and are administered after verify the expiry date, perform visual inspection, ensure no contraindications. The 10 rights of medication: right patient, right frequency, right drug, right documentation, right route, right infusion, right time, right approach, right dose, right duration. These are 10 rights of medication. A strategy to avoid error involving high alert medication. Medication arrangement. Avoid storing like, look like, or sound like. Here there is examples. It's look alike. But this 50 milligram and this 10 milligram. We should make highlight stickers. Okay. The 4 goals: ensure safe surgery. The hospital also develop and implement a process for preoperative verification and surgical invasive procedure site marking. The hospital develop and implement a process of timeout that perform immediately prior to the start of invasive surgical procedure and the sign out that is conducted after surgery. Here, marking the correct surgical procedure. Permanent marker is better than with instantly recognizable mark. Should be made by the person performs the procedure. Should take place with patient awake and aware. Okay, it should take the place that we will make the marker for the patient when he is awake and aware. It's so important. لازم المريض بتاعي يبقى واعي وصاحي وانا بعمل الماركر للسيرجري عشان ما اعملش المكان غلط. ممكن I will do in the right leg and the procedure in the left leg. Okay, it should be in patient awake and aware. Marking should be done in bilateral and multiple cases. The mark should be an arrow and extend near the incision site and remain visible after the application of skin preparations. Okay, the marking should be done by the one who will perform the surgery. Better, the person who will perform the procedure, he is the one should be make the marker to know the right side and the right side and the right side he will do the surgery about it here. Marking should be done within 24-hour period shifting or to the OR. Pre-operative verification process using pre-operative checklist, verify the correct sites and procedure and patient. Ensure that all relevant document, image, and studies are available, probably labeled and displayed. Verify any required special equipment and or implement are present. Here we'll conduct a timeout process just before surgery. Okay. التايم اوت بيكون قبل العملية. Sign out process before the patient leave the operation room. في time out وفي sign out. Sign out قبل ما المريض يطلع من غرفة العمليات لازم نكون برضو مشيكين على كل حاجة قبل ما يطلع المريض من الغرفة. Before the patient leave the operation room, verbally confirmed by the team, typically nurse, name of surgical, okay, invasive procedure that was recorded or written, completion of instrument, الاسم، اسم العملية والبروسيجر اللي اتسجلت. أهم حاجة برضو الانسترومنت، الأدوات بتاعتي كلها كاملة. الليبلينج برضو زي ما قلنا في العينات. Any equipment problem to be addressed. Okay. Verify the patient by patient signature or consent form. These are rules of obtain informed consent. That the patient has all information needed regarding the risk, benefit, alternative of the procedure to make an informed choice. Ensures that informed consent was complete. Valid before patient taken for surgery or procedures. Here we will talk about the healthcare associated infection from the hospital, how we will reduce risk, hand wash its vigors are brief rubbering together all surface of leather's hand, followed by rinsing under a stream of water. Here, the 5 moments. Before touching patient, before cleaning aseptic procedure, after body fluid exposure risk, after touching patient, after touching patient's around. And Dr. Noor already, she explained about it all. Yeah. Here, the hand wash technique. We have 13. And what is the time? What is the time of hand washing it should take? Hand washing. How many seconds it should take, or how many minutes it should take when we will make hand washing? Anybody knows about it? I think Dr. Noor also she mentioned. Yes, 20 hand washing, not hand rub. ازيك يا هاي عاملة ايه؟ Yes, excellent Rami. 40 to 60 seconds. Yes, going to 1 minute. Mad, yes, excellent also. We have 40 to 60. تسلمي يا رب يا هيا ما تحرمش. We have 40 to 60 hand washing should be take 40 to 60. Hand rub يا هيا 20 to 30. Half of this time also. Okay? This step also for hand rub. We have 8 steps. Hand wash, like we told before, it's 13 steps. Okay? Here, hand rub, 8 steps. Our hand before and after. Before hand wash or before hand rub and after. Who is responsible for infection control? So important questions. Who's responsible? مين المسؤول عن مكافحة العدوى في المستشفى؟ Who is responsible for infection control, please? Infection control themselves, everybody. Yes, yes, excellent, excellent, excellent. All stuff, everybody, كل اللي قال, everybody. Rami, excellent. Everybody, all of us, we are responsible for infection prevention. Okay? Not only infection control department. The policies, the procedures, the process, like that for infection control department. But who is responsible for preventing infection? All healthcare workers, they are responsible for preventing infection. هيا استشاري أمراض معدية، شكرا ليكي. اتشرفت بالمعلومة الحلوة دي. Yes, okay, thank you Rami. All the stuff, Qasim also. Excellent for all. Mi'ad, infection controls themselves. Yes, sure, infection controls themselves, but with all healthcare giver, all healthcare worker. لا بالعكس لازم تبقى مبسوطة يا هيا، كفاية ان انت شاركتي وان انت بتجاوبي يعني وملتزمة ومركزة. Thank you for you really excellent. Thank you. I'm so proud of all of you. Infection common to all healthcare setting: catheter associated urinary tract infection and PSI bloodstream infection, pneumonia, this I told yesterday, VAB, duration of hand washing. Here, the hand rub 20 to 30, the hand wash 40 to 60 seconds. Our aseptic procedure 1 to 2 minutes. The surgical procedure hand washing is 3 to 5 minutes. Okay, I will ask again about it later. Duration of hand washing, rub of hand hygiene, all hand hygiene, rub or washing or aseptic procedure or surgical procedure. Okay, donning personal protective equipment from CDC. Here are the steps how to wear our PPE. Already Dr. Nora, she talked about it. Doffing, here are the steps also. Type of isolation with the corresponding transmission-based precaution cards. Isolation sign. Here, type of isolation, airborne. The precaution card will put blue. Special consideration, room type, and the PPE. Okay, for airborne, negative pressure. Keep door and window closed. The PPE, N95 and gown, face shield, gloves. Okay, for droplet isolation, room type, single room. If not possible, room with patient that has the same organism but no other infection. Okay, and the card, it will be red. The PPE, regular mask, gown, face shield, gloves. The contact isolation, room type single, also like the droplet, if not possible, with same organism but not other infection. Here we will wear our PPE, gowns and gloves. Here we have the important note: when we will transfer the patient from our department to other department, we should wear mask. We will give the patient also to wear the mask when we are wearing the PPE. And when it's isolation patient, we should inform the department before we will go there to tell the staff to wear their PPE also. Okay. The goal 6, reduce the risk of patient harm resulting from fall. The hospital develop and implement a process to reduce risk in patient population, outpatient population. Classification of fall: accidental patient trip or some other misshape cause the patient to lose balance. Accepted physiological patient is identified at admission to be risk of falling and subsequent fall. The indicator of fall assessment on admission, transfer to other unit, change patient condition after fall, and change of medication. This the indication. Also, there is category and colors. Low risk of falling, it's green. Medium risk of fall, yellow. High risk of fall, it's red. Contributing to falls, recent, age, secondary diagnosis, medication, gait, vision, footwear, mental status, IV access, ambulatory aids, restraint use, or environment. How to prevent preventive intervention? Communication, orient patient, patient family education, and shift report, plan of care round every 2 hours. The toileting, implement bladder and bowel program, provide commode of at bedside, provide bedpan at easy reach. The environment, like bed, bedside table. Here, low position, braked, locked, side rail up, the bedside table, food table within easy access. No clutter, remove unnecessary furniture, arrange the room. Here our reference from the International Patient Safety Goals. Now we finish. You have any questions in this slide and this lecture about the National Patient Safety Goals and International Patient Safety Goals? It's so important to know about it for all healthcare giver, medical staff, all medical staff, they should know the 6 goals of International Patient Safety Goals. And I preferred it will be like card with all medical staff. Thank you هيا. تسلمي تسلمي. أي سؤال عندكم؟ أي سؤال؟ You have any questions about national safety goals and international safety goal? Thank you, Abdrazak. Thank you. Thank you. No questions? Okay, I will ask. I mentioned before how many types of hand hygiene and hand washing, and the times also for hand wash, hand rub, the surgery procedure. Thank you, Ryan. شكرا يا هيا. Thank you, ابتسام. اوكي يلا قولي. قولي يا هيا. أنا عارفة إنها سهلة عشان كده سألتها. يلا قولي لي ال4 أنواع بقى يا هيا، طالما أنت قلتي إن دي سهلة. قولي لي ال4 أنواع اللي أنا اتكلمت عنهم. أول سؤال. Yes, 42 seconds to 60. For what يا رامي? Yes, hand wash. Okay, good. 22 60, 22 30. Okay. This is the second one, Rami. Thank you. About hand rub. Okay. Yes, Mad. Thank you. Excellent. 22 30. There is 2 more surgery procedures and aseptic procedure. Who knows about aseptic procedure? Thank you. 1 to 2 minutes. This surgical. I talk about it before, yeah. Mad. Surgical 3 to 5. Okay. Surgical يا معاد 3 to 5. The aseptic procedure it's 1 to 2 minutes. Okay. Haya, I am asking about the duration of hand washing when there is aseptic procedure and surgical procedure. Thank you, Tariq. Okay, we finish this lecture. We will start other one, role of for environment for disinfection and cleaning. Never mind, yeah, Maad, never mind. Okay, just seconds until I will share my slides. Yes. Hello. Now we'll talk about environmental cleaning and disinfection. At the first, I want to ask, did you know the difference between cleaning and disinfection? We have different between cleaning and disinfection. What is the difference? We will mention here also why cleaning and disinfection matters. What is the contact time and the reflection. Here the patient environment, this all our environment. You see here, there is sink. It's important, so important in each rooms for ICU or isolation. It's so important we have sink like that to hand wash or to make our hand hygiene. ده من معايير السلامة برضو لسباهي إن لازم يبقى فيه للإي اس ار. اوكي، إن يبقى فيه أحواض زي كده في الأقسام الاي سي يو، في الايزوليشن اللي موجود في الاي ار او في الأقسام فوق مثلا، او في الأقسام يعني والوحدات، او في الطوارئ. ايزوليشن في الطوارئ يبقى في سنكات زي دي، في أحواض موجودة، عشان دي من المعايير المهمة جدا. قبل ما نعمل أي منشأة لازم تبقى الحاجات دي موجودة، خاصة عشان معايير سباهي. This the sink it's so important, okay? Our learning objective, we will describe the difference between cleaning and disinfection, discuss why it's important to follow the label instruction and disinfectant product. Here's the questions. I need all to attend please and answer. Which one of this definition is the correct? Cleaning is killing germs, disinfecting is removing dirt and some germs, or disinfecting is a type of cleaning with chemicals, or cleaning is a type of disinfecting germs, cleaning is removing dirt and some germs. sorry there is internet problem. معلش أنا آسفة جدًا، في شكله النت علّق. الslide ظاهر دلوقتي، الslide ظاهر واضح؟ ما فيش صوت؟ أوكي، طيب تمام. يالّا أنا كنت باسأل هنا إيه التعريف الصحيح للcleaning and disinfecting؟ Please share with me the answer. أول واحد cleaning is killing germs، يعني التنضيف بيقتل، إن هو معناه إن يقتل الجراثيم، والتطهير إزالة الأوساخ والجراثيم، والّا التطهير نوع من التنضيف من أنواع التنظيف، والتنضيف بالمواد الكيميائية، والّا التنضيف نوع من أنواع التطهير، والّا التطهير بيقتل الجراثيم، والتنضيف إزالة الأوساخ والجراثيم. Which one is the correct definition؟ مين قال دي؟ عبد الله. عبد الله قال دي، هيا قالت الأول. عبد الله yes excellent يا عبد الله، excellent يا عبد الله. معاد قالت the first one also. لا. Thank you for your answer. Really I'm proud of all. الإجابة الأخيرة دي هي the correct answer. التطهير هو قتل الجراثيم، والتنظيف عبارة عن إزالة الأوساخ وبعض الجراثيم. Okay. Disinfectant is killing germs here. The fourth one. تمام. الكليننج احنا يعني بتنضفي الأوساخ أو الأتربة أو بعض الجراثيم، كلها مش كلها. تمام. بعض الجراثيم ده الكليننج for our environment. but disinfectant لأنه في إن احنا نقتل الجراثيم، disinfectant بياخد وقت، ليه time، وبيكون عن طريق محاليل معينة أو معقمات معينة، مواد مطهرة معينة، وبياخد وقت، ومش فيها ليها إجراءات معينة، إن إحنا ما نمسحش وقت ما بنعمل الديسنفكتنت، يعني ما يكونش فيه مسح للإنفايرومنت. إحنا عملنا disinfecting وحطينا مثلا المحلول المطهر في التابل مثلا، فده ياخد وقت لحد ما ينشف، ما نمسحش فيه، ما ننفخش عشان ينشف بسرعة. تمام. بنديله وقته for disinfecting عشان يقتل الجراثيم، لأن بعض الجراثيم بتاخد وقت in our environment، بيبقى موجود في الأسطح لمدة طويلة. عشان كده مهم جدا الديسنفكتان بالمطهرات المعينة المحددة اللي بعد الجراثيم كمان. Okay, you understand يا معاد؟ But cleaning, we are only removing the dust, dirt, and some germs. Okay, thank you. What is the difference? Here, the definition. Cleaning is a process that removes things like dust only, dirt, grime, and other spill, smear, and everyday messes from surfaces along with some grains. But disinfection is a process that kills grime. Okay? Why we need to clean and disinfection? ليه التنظيف والتطهير مهم جدا؟ ده especially in healthcare organization. يعني احنا ممكن يبقى فيه تنظيف وتطهير في all organization, but in the healthcare organization it's so important. Why? لأن في بعض المرضى اللي هيزورونا عندهم ضعف في المناعة، فالجراثيم دي كلها هتأثر فيهم كده، يبقى فيه healthcare associate، هيبقى فيه health infection acquired، هياخدوا عدوى من المستشفى. Okay. In healthcare, we have patients who are ill or weak. Gram are more likely to cause problem in this patient because their immune defense may not be the same as someone who is healthy and living at home. The healthcare environment should be kept clean. Why we should keep our environment is clean? To stop grams from spreading. Where and when? Patient rooms, high touch surface like bed rails, keyboards, light switch, surface and objects that often have a lot of grams on them, like toilet seats. Here I have picture, I think, about it. Or no. Okay. What is the contact time? Contact time, sometimes called dwell time. This is amount of time disinfectant need to sit on a surface. زي ما قلت أنا من شوية، الوقت اللي بناخده عشان disinfection for our surface or our environment without being wiped، من غير ما نجففه away or disturb to effectively kill germs، عشان يقدر يبقى فيه إن هو يقتل الجراثيم بطريقة فعالة. Here the good idea. This from the IBA، دي وكالة للحماية من البيئة. هم اللي عاملين البوستر ده. دي وكالة مخصصة للحماية البيئية. اوكي، IBA اسمها IBA تبع CDC برضه. The best practice during the COVID-19 pandemic. Here is the good idea. Here how be careful. How here don't or do it. Okay. Here we'll talk about the disinfectant labels. ده برضو مهم جدا إن إحنا عشان نعرف المعقمات أو المطهرات اللي بتأثر على كل نوع من أنواع الجراثيم أو الوقت اللي هياخده for this contact time اللي إحنا نقدر نعمل بيه التطهير. بتكون الإجراءات دي كلها مكتوبة على نوع الديسنفكتن أو الديسنفكشن المحلول أو المعقم أو المطهر اللي بيكون موجود في المستشفى. that is labels. we should read the entire labels. What information do you need from the disinfectant label? Is the product EBA approved? On which surface can the disinfectant be used? What grams has the disinfectant been proven to kill? Should the product be diluted? What is the contact time? الحاجات دي كلها لازم نبقى عارفينها، ودي اللي احنا بنحتاجها في الليبل اللي بيبقى موجود في نوع المطهر أو المعقم اللي موجود عندنا في المستشفى. المنتج ده هل معتمد؟ أو على أي سطح نقدر نستخدم المطهر ده؟ وإيه الجراثيم؟ يعني كل مطهر أو كل معقم ليه أنواع من أنواع مثلا السيرفس، يعني مثلا جهاز الدياليسيس ليه معقمات أو مطهرات معينة ليها، مش أي مطهر إن احنا نعمل بيه ال clean and disinfectant of our machines. اوكي، طب what is grams has disinfectant has been proven to kill، أو الجراثيم اللي المفروض ثبت إن المطهر ده فعال ليها، وهل إن احنا نخفف المنتج بتاعنا ده ولا نستخدمه زي ما هو كده على طول؟ الحاجات الإجراءات دي كلها لازم نقراها من الليبل اللي موجود عندنا في المعقم. وإيه هو وقت الاتصال برضو؟ يعني وقت الاتصال يعني الوقت اللي احنا هناخده عشان to clean this our environment. Okay. Here, do and don't of disinfection. Do follow the listed contact time. اللي المفروض نعمله أو ما نعملوش لما نعمل التطهير بتاعنا. هل إحنا بنتبع وقت الاتصال المذكور معانا في الليبل؟ وليه نتبع وقت الكونتاكت تايم؟ عشان نضمن إن العناصر إن طهرنا الجراثيم اللي موجودة. طب إيه الحاجات اللي المفروض ما نعملهاش؟ إن إحنا don't rush, don't wipe, don't blow. الوقت ما نتسرعش في الوقت، نستنى زي ما الإجراءات اللي مكتوبة في الليبلز قبل استخدام الأشياء والأسطح أو قبل دخول المريض جديد للغرفة. تمام؟ ما نتسرعش في إن إحنا نطهر المكان بسرعة عشان مثلا المريض جه وما لحقناش. لأ، you should take your time. ما نمسحش برضو الأسطح ونخففه بشكل أسرع. don't wipe, don't blow. برضو ما ننفخش على السطح عشان ينشف بسرعة، لازم ياخد وقته. don't blow on the surface to dry it faster. Here, the which disinfectant kill COVID-19. find ده بيكون الحاجات دي كلها في لستة موجودة في الإيبا. Diverse moment of environment disinfectant before placing a food tray. Here, this in ICU or surgery rooms, before placing a food tray on over bed table, after any procedure involving face or respiratory secretion within the patient bed space, before or after any aseptic practice wound line, after assistant with productive cough or vomiting anytime surface, are visibly soiled after any object used by a patient touch the floor. Here, some moments also of environment disinfection before placing food tray, after procedure of involving faces, respiratory secretion, before and after aseptic procedure, after patient take a bath within bedside space, after assistant for patient when he's coughing or vomiting, and when surfaces are visibly soiled. Here's the culture of overbed table before cleaning. And after cleaning here. Here there is some mistake culture. Anything we touch it, we should clean it. Do you part when you see a patient? What is your reflection? What did you learn today? You have learned anything today in this lecture? What is your reflection, please? طب عندكم أي yes. Thank you Haya. Excellent, and thank you for you really. طيب, can I ask what is the difference between cleaning and disinfectant? Disinfectant. Yes, please. There is any difference between cleaning and yeah. Excellent. Yeah, really. I'm so proud of you. التنظيف بيقتل شوية من الجراثيم والأتربة والغبار. ده تنظيف. يعني مش بيبقى حاجة عميقة يعني. يعني مش التطهير. Yes, excellent. التاني بيقتل الجراثيم. وبيبقى تنظيف عميق بياخد وقت. مطهرات ليها أنواع معينة من الجراثيم. كل في ليبلز لازم نقراها نقدر نخففها ولا ما نخففهاش، والوقت اللي بيكون موجود فيه كل ده في الليبلز. اوكي. Here the key takeaway: cleaning or disinfectant kill germs, like you told Yahya. Clean, remove visible dirt. It's important to keep the healthcare environment clean to stop the spread of germs. You should follow the instruction on disinfectant labels, especially instruction for contact time. That is our reference. And finally, please let us know how you enjoy today by completing the following feedback. Thanks again for joining my lecture. خلصنا المحاضرة دي كمان. عندكم أي أسئلة هنا؟ You have any questions؟ ناخد بريك صلاة عشاء ربع ساعة ونرجع نكمل المحاضرات بتاعتنا. فاضل محاضرة واحدة إن شاء الله ونخلصها بإذن الله. أوكي، بريك عشاء ربع ساعة ونرجع نكمل المحاضرة الأخيرة بإذن الله. Thank you, Matt. Thank you, Haya. Thank you for you also. Only 15 minutes or 10 minutes until we will pray Isha. Then we will continue the last lecture, inshallah, for today. Hello, السلام عليكم. تقبل الله منا جميعا. Now we'll talk about evidence-based guideline for reducing the cavity. جاهزين نبدأ؟ عليكم السلام، أهلا ريان. We will start إن شاء الله our last lecture. Catheter-associated urinary tract infection, this acquired infection. Catheter-associated urinary tract infection are one of the most common healthcare associated infection. It's a catheter is a tube insert into the bladder to drain urine. قسطرة بتتحط في البلادر عشان لتقليل أو استخراج البول يعني. Catheter are sometimes used after surgery or if you cannot control your bladder function. A urinary tract infection is an infection in any part of urinary system, such as urethra, bladder, ureter, or kidney. Cavity have been associated with increased morbidity and mortality healthcare cost and length of stay. مشاكل الكاوتي أو الالتهابات اللي بتحصل عن طريق القسطرة للمسالك البولية أو العدوى دي بتؤدي ممكن للممارضة أو الإعياء أو الوفاة وبتكلف تكاليف باهظة للمستشفى وبيعرض المريض إن هو يفضل موجود المستشفى لفترات أطول فكده هياخد أماكن أكتر مش هنقدر نستقبل مرضى أكتر لأن إحنا بقى عندنا infection from this catheter. Okay. The cavity is a common type healthcare associated infection. It presents 15% of healthcare associated infection reported to CDC, National Healthcare Safety Network. There are an estimate 5,060,000 nosocomial UTI annually. Okay, increased morbidity and mortality. There are estimated 13 attributable death annually. Cavity is the leading cause of secondary bloodstream infection with 10% mortality. Cavity is associated with excess length of stay 2 to 4 days. يعني المريض عندنا ممكن يقعد 5 أيام إحنا بعد after he has the infection he will be more. He's 5 days, it will be 7 days, it will be 9 days. He will stay with us in the hospital. Increased cost also 0.4 to 0.5 billion per year nationally. And necessary antimicrobial use. The definition: a catheter-associated urinary tract infection occurs when gram, usually bacteria, enter the urinary tract through the urinary catheter and cause infection. Here the number of 449,334 cavity event per year. دي الإحصائيات اللي طلعت في السنة 449,334. How to prevent that? insertion, securement, draining bag, hand hygiene by families, review for need, indication, alternative. We will talk about it all. Insertion, a step of hand washing. Perform hand hygiene immediately before and after insertion. Here, the insertion, use sterile things. It should be sterile. لازم كل الأدوات اللي احنا بنستخدمها تبقى معقمة. Use appropriate antiseptic or sterile solution for pre-urethral cleaning. Okay. Here, use appropriate antiseptic single-use packet. For catheter tip. Here. You should maintain also our aseptic technique. Place securely in the upper tight. Here we should put our catheter like that. And device will keep catheter in place. How we can put our draining bag? We should not put in the floor beside the bed like that. Draining bag should be below the bladder level. It's like that, it's below. Draining bag should be hang in the bed frame. Also, it should not touch the floor. مكانه الدريننج باج يبقى بالطريقة دي. Okay. Our hand hygiene or hygiene, maintain a sterile closed draining system. Here. And maintain an obstructed urine flow. Don't change indwelling catheter or draining bag at arbitrary fixed interval. Ensure that the bag is emptied period to transport. Before we will transport the patient from department to other department, or he has any process in other department, we should make empty our bag. Okay. Here we will explain also before we will leave to patient to go in his home. Explain the need of the catheter to patient and their family. أو بعد العملية مثلا we should explain why the patient he need this catheter. Review for need, incorporate observation of urinary catheter and bag into routine round. We perform simple check period transport to ensure that all lines are catheter are written. Is the catheter secure? Is the draining bag empty? الحاجات دي كلها لازم نشيك عليها. When should an indwelling catheter be used? We have appropriate use and inappropriate uses also. Appropriate use for indwelling urinary catheter. Patient has acute anatomic or functional urinary retention or bladder outlet obstruction, need for accurate measurement of urinary output in critically ill patient, preoperative use for selected surgical procedure, to assist in healing open sacral or perineal wound in incontinent patient, to improve comfort for end-of-life care if needed, or patient preference. This our appropriate use. The inappropriate use for convenience of nursing care، عايزين يرتاحوا مثلا من المريض. This inappropriate use to obtain urine for culture or other diagnostic test when the patient can voluntarily void, for prolonged post-operative duration without appropriate indication. So what is our cause and risk factor? Cautery occurs when grams enter and infect the urinary tract through the urinary catheter. This could happen upon insertion. If the draining bag is not empty enough, contamination of bacteria from a bowel movement, irregular cleaning, and if urine from the catheter bag flow backward into the bladder, prolonged catheter use is the number one risk factor for developing the cautery. What is our symptoms and treatment? Common symptoms of the UTI: pain or burning while urinated, pain in the lower abdomen or back, increased frequency of urination, increased urge to urinate, blood in the urine, fever, sometimes may be or not present along with the symptoms. These are our common symptoms. It's appear when there is UTI for this patient. He has pain in lower abdomen or back, increase of urination, blood in the urine also. Sometimes there is the symptoms, sometimes there is fever or without fever also. What is our treatment? The first, you should go to your doctors to see what is the treatment you should have or you should take. Sometimes there is antibiotic, or there is some surgery or like that. That if you have any symptoms above, see your healthcare provider the first. They will be able to diagnose your infection and determine if an antibiotic necessary. Gram are becoming more resistant to antibiotic and taking drug when not needed. Sometimes a gram, there is resistance from antibiotic. For this situation, you should ask your healthcare provider when you have any symptoms from this common symptoms we mentioned above, because sometimes your treatment is not antibiotic. Your doctor, he knows what your treatment. Okay? If you are given prescription, take antibiotic exactly how your healthcare provider recommended. Don't skip any dose. Share your medication. or save any leftover peel. Drink plenty of water to help clear the bacteria from your body. There is also phenozbriadine maybe help. This عبارة عن مسكن. He less the pain of this or discomfort but doesn't cure the infection. ده مسكن بس مش هيوقف الانفكشن اللي موجود عندي. Only for pains, because we mentioned the symptoms. There is pain or burning while you are have urinating, or pain in lower abdomen and or back, in your back also. If you take this medicine, continue taking your antibiotic at the same time. This also sign and symptoms for symptoms and sign for cavity. Hematuria, strong urine, leakage around the catheter, vomiting, dysuria, fever, chills, unexplained fatigue. This also symptoms for cavity. How we prevent, what is our strategy to prevent the UTI? Urinate before and after sexual activity. Stay well hydrated and urinate regularly. Take shower instead of bath. Minimize dashing and spray or powder into the genital area. Wipe front and back when toileting. This is the strategy for preventing UTI. Here there is video. I hope you can. How I can remote. Did you hear? Did you hear the video here? Hello, سامعين الفيديو؟ معلش ممكن فيدباك. سامعين الفيديو ولا لا؟ سامعين؟ انا موقفاه دلوقتي بس كنت سامعين الفيديو، الصوت والفيديو باين كويس؟ Hello, anybody can feedback please? Okay, thank you Tahani, thank you. هنا الأسباب اللي بتعمل الكاوتي، بتعمل الانفكشن، بتعمل العدوى للكاوتي، إن إحنا بنتأخر في إن إحنا نشيل اليورينري كاستر، مفيش improper aseptic technique, improper urinary catheter care and maintenance, and infrequent assessment of urinary catheter. دي الأسباب. هنا زي ما قلت برضو في زي ما قلت الباج of our patient it should not be up، يعني ما يبقاش كده فوق موجود هنا، أو إن هو يبقى لامس الأرض، ده برضو يعمل cause of infection of catheter. okay. Here they will talk about, they will mention about how to avoid CAUTI. هنا مهم جدا برضو training for the staff، ازاي يقدروا يركبوا القسطرة صح، وازاي يقفلوها صح، وازاي الطريقة، وازاي الأجهزة تبقى التريننج مهم جدا for our staff to prevent the infection of CAUTI. okay. السلايد ده حلو قوي في ان احنا نفتكر ازاي نعمل prevent للكاوتي by the alphabet of the CAUTI: catheter removal, promote removal, prompt removal here by the C, A, aseptic technique, urinary catheter insertion and maintenance. من هنا نقدر نفتكر ازاي نعمل prevent للانفكشن بتاعت الكاوتي بالحروف دي. يعني انا من الناس اللي بفضل ان يبقى فيه كل حاجة يبقى ليها حاجة معينة عشان اقدر افتكرها بيها يعني بسهولة. like here the alphabet CAUTI: catheter remover, aseptic technique, use regular assessment, assess need of urinary catheter every shift. T, training for catheter maintenance, maintain an obstructed urine flow, closed draining system, routine our hygiene. دي التريننج اللي أنا قلت عليها مهمة جدا 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 to train all our staff about how to prevent the infection. Okay. I, in continuous care planning, prevention of urinary retention, consider alternative condom catheter, female urinal toileting routine. Here I have questions, please. Always make sure you really need me before using me. How we can be sure when we need this catheter or no? But and how we will be sure? ازاي اتاكد قبل ما ابقى ان انا هستخدم القسطره؟ لازم ابقى متاكد. ازاي هتاكد طيب ان المريض ده محتاج قسطره ولا لا؟ بالاعراض اللي قلنا عليها. صح، بالاعراض او المريض محتاجه ليه في الجراحه، بعد الجراحه، خاصه بعد الجراحه. تمام. Now we'll talk about guideline for prevention of catheter-associated urinary tract infection. Our table of content. The summary: to evaluate the evidence on preventing CAUTI, we examine data addressing 3 key. هنسأل 3 أسئلة. Who should receive urinary catheter? For those who may require urinary catheter, that's the best practice. What is the best practice for preventing CAUTI associated with obstructed? Okay, this is the 3 key question we should address before we examine. When we will ask who should receive urinary catheter, when the urinary catheterization necessary, what is the risk factor of the CAUTI, what population are high risk mortality related to urinary catheter. The second question, for those who may require urinary catheter, what are the best practice? Especially, what is the risk and benefit associated with different approach to catheterization, different catheter or collect system, different catheter management technique, and different system intervention, like a quality improvement program. Appropriate urinary catheter use. The first one, insert catheter only for appropriate indication and leave in place only as long as needed. Okay. Then perform hand hygiene immediately before and after insertion of any manipulation of catheter device or site. Ensure that only properly trained person hospital person or family member or patients themselves also, who know the correct technique of aseptic catheter insertion and maintenance are given this responsibility. This is all in guideline, evidence guideline based, evidence-based guideline, okay? And in the acute care hospital setting, insert urinary catheter using an aseptic technique and sterile equipment. This all in appropriate urinary catheter use, okay? Here, proper technique of urinary catheter insertion. The continuous of proper technique for urinary catheter insertion in the non-acute care setting, a clean, like non-sterile technique for intermittent catheterization in acceptable and more bacterial alternative to a sterile technique for patients requiring chronic intermittent catheterization. And probably secure indwelling catheter after insertion to prevent movement and urethral traction. Unless otherwise clinically indicated, consider using the smallest pore catheter possible, consistent with good draining to minimize bladder, neck, and urethral trauma. If intermittent catheterization is used, perform it at a regular interval to prevent bladder over dysentery. Here, proper technique for urinary catheter maintenance. Following aseptic insertion of the urinary catheter, maintain a closed draining system, maintain an obstructed urine flow, use standard precaution, including the use of gloves and gown as appropriate during any manipulation of catheter or collecting system, complex urinary draining system, changing indwelling catheter or draining bags at routine. Fixed interval is not recommended. Rather, it's suggested to change catheter and draining bags based on clinical indications such as infection. Unless clinical indication, like patient with bacterial airborne catheter removal post urologic surgery, don't clean the preuretals area with antiseptic to prevent cavity while the catheter is in place. We will make routine hygiene cleans of the metal surface during daily bathing or showering is appropriate. Unless the obstruction is antiseptic, then we will make routine installation of antiseptic or antimicrobial solution into urinary draining bag is not recommended. Clamping indwelling catheter barrier to removal is not necessary. The catheter materials, if the cavity rate is not decreasing after implement comprehensive strategy to reduce rate of cavity, consider using antimicrobial or antiseptic impregnated catheter. Here, hydrophilic catheter may be preferable to standard catheter, and silicone also may be preferable. The management of obstruction. If obstruction occurred, it's likely that the catheter material is contributing. We should change that catheter. Okay. How we will specimen collection, obtain urine sample, especially special separation of catheterized patient. This all the proper technique for the urinary catheter maintenance. Now we will talk about quality improvement program. The first, we will implement quality improvement program or strategy, enhance appropriate use of indwelling catheter. Why we need to make this quality improvement program? To reduce the risk of CAUTI based on a facility risk assessment. The purpose, at the first one, the purpose of the program should be to assure appropriate utilization of catheter, to identify and remove catheter that are no longer needed, to ensure adherence to hand hygiene and proper care of catheter, a system of alert or remind to identify all patients with urinary catheter and access the needed for continued catheterization, the guideline and protocol for nurses direct remove of necessary urinary catheter, education and performance feedback regarding appropriate use, and guidelines and algorithm for appropriate pre-operative catheter management, and the last one, protocol for management of post-operative urinary retention, such as nursing direct use, intermittent catheterization, and use of bladder ultrasound scanner. This is the purpose to use our program for quality improvement. Here, administrative infrastructure, the provision of guideline, education and training, the supplies. It should be the catheter insertion are readily available. System of documentation, the surveillance resource. Here, the surveillance, consider surveillance for CAUTI when indicated by facility-based risk assessment. Identify the patient group or unit which is conduct surveillance based on the frequency of catheter use and potential risk of CAUTI. The second one, use a standardized methodology for performing CAUTI surveillance. Example of metrics that should be used for CAUTI surveillance include we have the how many metrics, like number of CAUTI per 1,000 catheter days, or number of bloodstream infection secondary to CAUTI per 1,000 catheter days also. This all example of metrics. Catheter utilization ratio, urinary catheter days per patient days, multiple 100. Okay. Here the strategy and the effect of implementation of the protocol for management of CAUTI in Saudi Arabia. we have three examples. Here, hand hygiene is the first effective strategy followed by infection control to minimize health-associated infection and ensure patient safety in several studies worldwide in Saudi Arabia. Okay. Here, the hospital, university affiliated hospital in Khobar, reduce the rate after they make the quality improvement project. They reduce the rate of cavity from 3.73 in 2014 become 2.2 in 2015. The rate it reduced from 3.7 to 2.2 in 1 year. It's so good really after this improvement quality improvement project. Then in 2016 also, because we told before yesterday, any improvement project we need to be sustained. Also after 1 year, they have decreased also for the rate of cavity, become 1.75 in 2016. The study suggested that educational intervention and enhancement of hand hygiene compliance as a part of multi-component strategy implementing in health care staff practice reduce of health associated health associated infections. Okay. The second one, this is the first one, this I told university affiliated hospital في الخبر. Here also in King Abdulaziz Specialist Hospital in Taif, they also conduct project from 2011 until 2013. One study in Saudi Arabia conclude that most beneficial technique of infection control practice to reduce cavity is removing the catheter as soon as possible. Here, our project about removing the catheter as soon as possible. Okay. Here about the strategy of hand hygiene. The second one, removing the catheter as soon as possible. The study was conducted between 2011 until 2013 in King Abdulaziz Specialist Hospital. The expected removal of urethral catheter as soon as possible reduced the rate for cavity of cavity min 3.5 become 2.9 per 1,000 catheter day in 2011 and 2012. Then they achieve Sorry for this interval. Here there is other study also in Saudi Arabia in Aramco medical self organization. They showed a higher of during associated infection rate was catheter associated urinary infection at the ICU ward. The study indicate that cavity was most common with percentage 42.2 during the period from 2004 until 2011, but after implement the cavity protocol was reduced from 6.7. Just a second. After they implement the cavity protocol, the rate reduced from 6.7 become 3.4. It's so nice, which indicate a linear trend in the reduction rate of cavity from beginning to the end study. Here also this is the last study was conducted by collecting data from adult ICU over 9 years in Tertiary Hospital with 28 beds in western region of Saudi Arabia. Cavity were reported at a higher rate, 2.3 per thousand device day between 2008 until 2010, which initiated the implementation of an infection control protocol for cavity in ICU for the hospital. After applying this protocol in 2011, the rate reduced from the 2.3 become 0.3 only. Then further also reduced to 0.1 and 0.2 in 2015 and 2016. Here my reference for the evidence-based guideline from CDC and ARC and MOH. Did you have any questions? I finished my lecture. Did you have any questions? Hello, everybody. You have any questions? Sorry, I'm talking and there is our microphone is closed. I finished already. You have any questions? Thank you, Matt. Thank you. Thank you for all attendance. نلتقي غدا بإذن الله. نكون خلصنا كده النهاردة المحاضرات بتاعتنا. And good night and have a nice مباراة. فين عبد المجيد؟ يلا thank you. ولا عبد الرزاق؟ هو حد فيكم كان عايز الماتش يعني. ف good night and tomorrow إن شاء الله we have also still lectures. اجهزوا بكرة عشان يبقى في أسئلة كتير إن شاء الله. Thank you for all. Good night.